Sky demonstrates full abduction without gravity. Later in the evaluation, we will test her shoulder abduction.
Coolest.
To begin the evaluation, Sky is tested in a supine position.
Yeah.
By encouraging her to move her arm
Everybody
in
can
a
hear, right?
sideways direction, her shoulder abduction with gravity eliminated can be tested.
Okay.
Hold it there. Push hard on your tummy. There it is. To demonstrate how to effectively assess children, we will be evaluating Sky and Mathumitha. Both children have brachial plexus lesions on their right sides. To begin the evaluation, Sky is tested in a supine position. By encouraging her to move her arm in a sideways direction, her shoulder abduction with gravity eliminated can be tested. Here, Sky demonstrates full abduction without gravity. Later in the evaluation, we will test her shoulder abduction against gravity. To test shoulder adduction with gravity eliminated, Sky's arm is fully abducted. Then Sky is simply asked to bring her arms to her side. Since she is demonstrating strong adduction, she achieves a score of 7. It is not practical to test this movement against gravity. Elbow extension against gravity is also determined in a supine position. Sky shows a full range of motion and achieves a score of 7. If less than full range is obtained, gravity eliminated extension must be tested in a sitting position. Gravity eliminated shoulder flexion is the only movement tested in a sideline position. Movement is stimulated in a forward direction. In this case, we can see Sky compensating for her shoulder flexion by arching her back. Since Sky can forward flex her shoulder a little more than half range, she scores a 3. As she did not achieve a score of 4, she will not be tested in an against gravity position. However, to demonstrate how shoulder flexion against gravity should be tested, Mathumitha raises her arm in a forward and upward position. She shows a full range of motion and scores a 7. To test shoulder abduction against gravity, stimulate sideways movement of the arm. To encourage Mathumitha to abduct her shoulder sideways, her movement is led with a toy. We can see she has full range of motion and scores a 7. Internal rotation of the shoulder is tested by holding Mathumitha's upper arm against her side. Her elbow is flexed to 90 degrees. Since she is an older child, Mathumitha is asked to mimic the movement of the evaluator. Mathumitha demonstrates strong internal rotation in this position. The score is 7. External rotation of the shoulder is also tested by holding Mathumitha's upper arm against her side and flexing her elbow to 90 degrees. She is asked to move her hand outward. Whereas the evaluator is showing full external rotation, Mathumitha can only externally rotate her arm half the full range of movement. She scores a 2. Gravity eliminated elbow flexion is tested by supporting the child's shoulder at 90 degrees of abduction. Movement should be stimulated towards elbow flexion. Sky demonstrates a full range of motion with gravity eliminated. She will now be tested against gravity. Elbow flexion against gravity is tested with the child's upper arm held at her side. Movement is stimulated towards elbow flexion. Sky does not demonstrate full elbow flexion and scores a 6. If we check Sky's range passively, we can observe full range of motion. The presence or absence of gravity has very little effect on scoring pronation and supination. A simple position for testing these movements is with the elbow flexed to 90 degrees. Pronation is stimulated by stroking the hand in a downward direction. Mathumitha's movement is approximately half range. Her score for pronation is 2. Supination is measured in the same position. Since Mathumitha's supination is just over half range, her score is 3. To test gravity-eliminated wrist flexion, Mathumitha's elbow is flexed to 90 degrees with her forearm in a neutral position. She reaches for a sticker that is offered to the palmar side of her hand. She demonstrates full range of gravity-eliminated wrist flexion. This movement will now be tested in an against gravity position. Wrist flexion against gravity is tested with the forearm fully supinated and the wrist extended. Mathumitha reaches for a toy that is presented to the palm of her hand and demonstrates full wrist flexion. She scores a 7. To test gravity-eliminated wrist extension, Mathumitha's elbow is flexed to 90 degrees with her forearm in neutral. She is encouraged to reach for a sticker with the dorsal side of her hand. She cannot fully extend her wrist with gravity eliminated and scores a 3. Since she does not have full range of movement with gravity eliminated, we will not test her against gravity. To test gravity-eliminated finger flexion, Mathumitha's elbow is flexed to 90 degrees with her forearm held in a neutral position. Finger flexion scores are assigned as a fraction of movement from the fingertips to the palm. Although Mathumitha has a wrist contracture, she demonstrates full finger flexion with gravity eliminated. Mathumitha's finger flexion should be tested in an against gravity position. Her forearm is fully supinated and her wrist is held in a neutral position. She is asked to cover a sticker placed in the palm of her hand. In doing so, she demonstrates full finger flexion against gravity and scores a 7. To test gravity-eliminated finger extension, Mathumitha's elbow is flexed to 90 degrees with her forearm in neutral. When she is asked to open her fingers, she demonstrates full gravity-eliminated finger extension at the metacarpophalangeal or MCP joints. Since she shows full range of motion with gravity eliminated, Mathumitha's finger extension is tested in an against gravity position. Finger extension against gravity is tested with the forearm fully pronated and the wrist held in a neutral position. Once again, Mathumitha is asked to lift up her fingers. She achieves full finger extension against gravity and scores a 7. To test thumb flexion, Mathumitha is directed to reach for a sticker placed at the base of her little finger. Movement is observed at the thumb's MCP joint. Mathumitha demonstrates full thumb flexion and scores a 7. In testing thumb extension, the presence or absence of gravity has very little effect on scoring. Mathumitha is asked to give us a thumbs up to demonstrate that she has full thumb extension against gravity. She scores a 7.
So this is how we are conducting the scoring of HSCMS at our clinic also. Now, what Curtis has done that, she placed the child in supine position and what all the moments which are possible to assess in the supine position she assessed. For example, the elbow, against gravity elbow extension. Okay. Adduction and abduction. Eliminated gravity abduction in supine. And then she turned a child into a sideline position and she checked the forward flexion of shoulder, that is eliminated gravity. And then rest of the all the movements she checked in the sitting position. Now, as she said that effect of gravity on the pronosupination and internal rotation, external rotation is very less. So we have to take a reference from the opposite side. Okay, and then you have to assign the score. So far, anybody is having any doubt about the HSCMS? Now, Dr. Maulin Shah will give the little bit. Yeah. Uh, can somebody give the mic to Dr. Prayas? उनको उनको दीजिए.
Thank you. So, are there any special considerations when we are checking on a neonate? Because these videos show children who are
Young
beyond
kids,
age.
yes. So we will demonstrate.
We have a neonate here, and I'll try to demonstrate how we check the neonate. We tickle them and let them move the extremity, and with practice you can generate this score. You may feel that there are so many movements and it is very time consuming, but you remember that if a child scores 7 in particular movement, like the child's wrist flexion, finger and thumb flexion is 7, so next time when they come to you, you don't need to check flexion. Okay, so you need to check only those movement which has not come, and with practice you can quickly generate the score. And
We also have the video. Your
yeah,
demo.
so this is a video which I have taken.
You want me to run?
You run it.
Yeah.
And a sound है उसमें देखो.
Anti-gravity in the flexion pull. So that will be score 7. Now here from
Anyway, so I'll give what now here, what I'm doing, I'm tickling the thumb, and thumb extension is not full. So we have plotted, because of the internet connection, the videos are very slow. Now you're stabilizing the wrist, and child, you are scratching on the dorsum, and see the index finger is going completely up.
again.
So wrist flexion has been scored as 6. When you're checking forearm, you stabilize the elbow and see what is the movement happening. Pronation is full, so it will be 7. And I'm stimulating to supinate. Child is not moving this way.
And move like
So supination is 0.
initiating a flexion even after pinching here.
Similar for elbow flexion, you are scratching on the arm anteriorly and see and feel the contractions of biceps. It's not happening. But the moment you lift the arm, child is extending the elbow completely, and so it is.
Deep triceps crease here.
So that's triceps is 7. Many children with very strong triceps and weak elbow flexion will show deep posterior crease at the elbow.
Child is doing bit of forward flexion. I'll turn on the side to see gravity eliminated forward flexion. You can see baby is doing forward flexion up to here. So it is gravity eliminated. This is 0.
And
This
when the
50%,
gravity
so let's say
eliminated is
50%
not full, then you don't need
eliminated,
to
bit more
do
than 50%
against
for
gravity mode.
looking at the adduction. You have to gravity eliminated adduction. I just abduct the limb and see how much the child brings it in or down. You can see she can bring it not 100%. So this is gravity eliminated adduction less than 50%, more than 50%. So it will be scored as 3. She is doing some bit of forward flexion against gravity, but as eliminated
stop it there.
gravity, forward flexion is not full. We will not consider it as a fact.
Let's stop there. And we have a newborn here, right? So can we have the child here? So now I'll demonstrate on a newborn, so you'll come to know how in real time we examine. So you don't have to stand up. You see on the screen, and I would request the AV people to give me that collar mic.
Hello, hello, hello.
This is the usual आप बोल बच्चे की तरह family wants to show you report because they have done that is what in their control. They have done the reporting, but we have to check the child first. आपको यहाँ पे ला बच्चे को इधर हाउ ओल्ड उम्र क्या हो गया बच्चे का तो चाइल्ड इज 2 months and 3 days old का बर्थ फुल टर्म पे हुआ था पूरा महीने पे जन्म हुआ था रोया था तुरंत लेट रोया था तो ऑक्सीजन देना पड़ा था कितना दिन देना पर रिपोर्ट में तुम बोलो हाउ मेनी डेज चाइल्ड वाज एडमिटेड इन 2 days नो वेंटिलेटर का जरूरत नहीं पड़ा परफेक्ट एंड फिर आपने एक्सरसाइज शुरू कर दिया तब बर्थ हुआ तब कोई मूवमेंट नहीं था हाथ का so at the time of birth child was moving the wrist that's what mom is saying but there was यहाँ पे मूवमेंट कोई नहीं फिर आपने क्या किया you started exercise आपने घर पे शुरू किया एक्सरसाइज की थेरेपी सेंटर पर घर पे किया ओके घर पे क्या एक्सरसाइज कराते थे बताइए हाँ so mom is doing the right thing wrist and shoulder movement and yeah so she is typically doing rule of 5 kind of exercise तो अभी भी आप ये एक्सरसाइज करते हो कितने टाइम करते हो घर पे हाउ मेनी टाइम्स अ डे जब भी वक्त मिलता है वो 3-4 टाइम्स एटलीस्ट शी इज डूइंग वेरी गुड ये निकाल सकता है ये आपका फर्स्ट चाइल्ड है सेकंड चाइल्ड है फर्स्ट इसका बर्थ वेट कितना था और पहले बच्चे का देखो so this both the babies are weighing same but most of the time the second baby weighs more than the first okay ध्यान रखो वो निकाल okay so I hope okay very good now they just guide them to focus where मामा आप इधर आ जाइए आप ये वाओ ये देखने को मिलता है बच्चा वेरी गुड so many a times in very young children you can do a Moro's reflex we know that when you lower the baby child would give a spontaneous movement that is one way if a child is very not showing any movement child is kind of asleep then you can elicit the Moro's reflex and that will give you the movement now I'm waiting for this gentleman to start no okay, good job chalo इधर focus करने का है so now this baby has right limb affected right and left limb is fully functional Now, can someone tell me wrist flexion? Let's start with the wrist. That's what I do. यहाँ पे लिखा, huh? So first you turn the wrist like this and try to put something here, and child will have a tendency to grab it. The child is doing wrist flexion up to this point, a little less than full, or you can say it is full. So I would score it 4, right, Tejas? And then to see anti-gravity wrist flexion, the child is having complete wrist flexion. So this will be plotted as wrist flexion as 7. Okay. Now let's look at the fingers. Oh. So you scratch here and child is doing complete flexion, you can see. And even against gravity eliminated, and against gravity child can touch the fingers to the palm. So this is scored as 7 as well. Now we'll look at the thumb. You see, this thumb is extending and child is touching it completely against gravity. So finger, thumb and wrist flexion is full. So which trunk is not involved here? So it is not either N3 or N4, right? Now we have to look into extension to see whether child is having Narakas 2 or 1. So let's look at the wrist and finger extension. So again, you turn the limb on sideways and try to scratch the dorsum. Sometimes you just open and see, but mostly you scratch here and child will be able to demonstrate. You see? So child is doing a little bit of wrist extensions. Many a times you might have to do it multiple times, you know. So I saw there is some flicker, a less than 50% gravity eliminated wrist extension. It was happening from the ECU. So this will be plotted as 2. And you see this finger? No, 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 no. And as they grow, you use some tactile stimulation, some toys which the child gets fascinated. Now, could you see elicit this some finger extension? You look at the video. See, but I would plot it as 2. So there is finger extension movement, but it all are gravity eliminated, and it is less than 50%. So now we can say there is which root is involved here. So C7 is involved. So this is either Narakas 1 or Narakas 2. It is Narakas 2, right? Now let us look at the C5-6 movements. So once you have checked with the wrist, you come to the forearm. No, no, no. And the child is keeping the forearm in pronation. There is a full pronation. And then you scratch it on the dorsum and this side and see if child initiates this. But there is no supination at all. So pronation will be scored as 7. Supination is 0. Because pronation is supplied by lower roots. Now to check the triceps, the best way is to lift the arm, bring it over the baby, and then see if child is able to extend it. For this, you can pinch a little bit at the triceps and see if child is able to lift it. Wait for some time. I assume the child would have some movement because there is a bit deeper triceps crease I can see here. So I can see some flickers in tricep, but not the true movement. So I would just plot it as 1. So all the C7 supplied muscles, triceps, wrist, finger extension is not working. So C7 root is involved. Now coming to the elbow flexion. Now you see the gravity eliminated elevation child is doing. So this elevation can be plotted as 3. It is not full. So now we will not check gravity against gravity elevation. I don't see any elbow flexion. To initiate the elbow flexion, we just scratch on the dorsum. Okay. And you scratch on the bottom so to see whether this child is having any adduction or not. Many a times you must be aware that certain degree of initial abduction happens from the pectoralis major. So if a child is having abduction of 20, 30 degrees, it's not plotted as a positive abduction. But 90 degrees is certainly gravity eliminated abduction. See? So, child is not producing gravity eliminated adduction as well or forward flexion. So that those scores, external rotation, adduction, internal rotation will be 0 at this point. So if I total my score, there is 777 for the wrist, finger and thumb flexion, that's 21. 3 for wrist extension, 24. 7 for pronation, 31. And 3 for abduction, so 33 or 34, right? So that is my today's score. And the child is 2.5 months old. So my diagnosis is Narakas 2, and the child is not improved in first 6 weeks. So it is not neuropraxia. So we are either dealing with a exontemasis or neurotemasis, which will come to know by 6 months with an HSCAMS of 31. So my treatment for this child is daily dose. We would like to observe this child. This child needs electrical stimulation in C5, 6 and 7 recruited muscles and passive range of motion exercises. We have to see that if child develops any contracture like wrist flexion contracture because wrist extension is weak, we would give a temporary cock-up splint to prevent that contracture to happen. Okay, so that was for a, as you said, for a small child. Yes. Yeah. That we have to palpate. The another movement which is the elbow flexion. No, many a time they flex with the forearm in pronation. So that is a movement from brachioradialis and not from biceps. So if a child is having anti-gravity elbow flexion without supination, that is highly likely to coming from the brachioradialis. So that you have to put your finger and make sure that the contraction is felt. Sensation that you ask mom, we'll ask mom and she would say, "Usko yahan tak pata chalta hai." You can ask kahan tak pata chalta hai. The mom is smart, so she would know this. Hello, how old is she? Hello. So she is an 11 months old baby, and here we are interested in. If we follow these children for HSCAMS, we want to see which roots are involved. Let's check it. इसको कौन सा हाथ है? Left. So turn this way. ऐसा घुमा दीजिए. Ah, very. So the left hand is involved. Yeah. So again, no. So again, if we quickly run through this, child is doing good extension and so I usually have melody chocolate. Something this combination of color golden and brown, all children are attracted. I've tried dairy milk, but something is there in melody. So you try that chocolate. And every child, now if she is doing complete wrist extension, finger extension. So C7 looks working well in this child. And let's see if child is having any elbow flexion. The child is doing elbow flexion with this in pronation. So I'm not completely convinced. What I fear is once we put her down, she would start crying. So let's see if I can gather some information when she is up. So she is doing elbow flexion as well. Two things I would like to know is whether she has active supination or not, and what is the amount of passive external rotation. Whether she has any internal rotation contracture. The best way is to check when the child is lying here and you check on both the sides to prevent any scapular compensation. And there is one more test known as towel test. At this age, we like to do the towel test, putting a towel on the top and see whether she is able to snatch it. Unko yahan sula. सर इधर रखो। तो विल चेक, थोड़ा रोएगी, चिंता मत करो, हाँ? 2 मिनट। ओ ओ ओ तो नाउ आपको इधर फोकस करना है, इधर भैया, हियर। पापा ये आप ये होल्ड कर दो, ये हाथ को पकड़ के रखो। आई एम पुटिंग द हैंकरचिफ on the child's face, and now you see, could you see that on the video? So I'm putting it again. So this is known as towel test. The child is able to pull the towel off. That means she has a good strength of biceps. And typically these children, they don't need nerve surgery because their anti-gravity biceps function is there. That, of course, this is not a very sensitive test. Now you can see the child is doing full external rotation. There is some lag in what we see here and what we do here. Oh. So she also had good gravity eliminated external rotation. So I will keep on watching on this child. Lily. Right. So she has good degrees of gravity eliminated external rotation. My current prescription would be to stimulate C5, 6, and 7. She has weak supination. She has weak external rotation and elevation. So we would stimulate and we'll keep on plotting. Now, if I have to plot, all the wrist extension and flexion are 7. So it is 42. Pronation is full 7. Supination is 1. So it is 50. Elbow flexion, gravity eliminated is very good. So I will plot 3. Adduction interrotation is 7. And forward flexion is 3. So that's how I score. Next time when the child comes, I have to look at only those points which are not 7, like supination, elbow flexion, abduction, and external rotation. So this child, if we have to also look for internal rotation contracture if they develop, then we have to treat that. And rarely some kids at 11 months, they have very good elbow flexion, but no, then we can do distal nerve transfer at a little till 18 months. So that would be my prescription of exam. She's fine. MRI, love. MRI, I do not advise MRI because my judgments are based on clinical thing. Now let's read the MRI report. Neurogenic mass in the middle trunk on the left side. So we'll show you how the MRI should be reported. Neurogenic mass is what? Is it an avulsion? Is it a neuroma? And the middle trunk is all functional. See, C7 is all functional. So MRI is a good thing, but many a time in our practice we have seen 50% fallacy. And so we now, and worldwide, all the big centers, they rely on clinical examination rather than MRI test. Now this child would need a short anesthesia for getting an MRI, and we know I'll be in fear to get my child's MRI done. So CMC Vellore, Dr. Anil Matthew is a very good friend of mine, and they have done high resolution ultrasound, and they have found, they compared with MRIs, and they have found initially good result. So they have just compared with MRI, but they have yet not compared with the clinical scenario. So that they are working on it. And maybe if that is if we see good outcome on ultrasound matching the clinical parameter, then we can use it and we can avoid MRI. So that is high resolution ultrasound is the next step in. Okay, so if let's one more child. Uska, we will discuss the malice ko and then we'll demonstrate on her. So I'll now talk about malice ko, which we use in older children where they can follow our commands. And malice ko is a score for shoulder function in obstetric palsy, which we use for the older children. So let's discuss that. Because of this internet connection thing, there is some lag. So what I talk, and that is fine. So, Dr. Das, this first baby, she's she is, I think, 2.5 months. We need to monthly evaluate her. And if she fails to show elbow flexion, wrist extension by 6 months, if her score remains the same, then she would have 5, 6, 7 neuroma, which is not conducting, that she might need a nerve surgery. So that we will introduce that surgery thing now. But if she keeps on improving, then fine. And you have to look at the wrist flexion contracture. If it is developing, then you can give a cock-up splint. The second baby is doing fairly well. I would observe her every monthly. She is not a candidate for primary brachial plexus reconstruction. But if she fails to demonstrate terminal strength, then she might need a distal nerve transfer, or we can do palliative tendon transfer at a later date as well. Okay, now coming to the Mallet score or modify Mallet score. Now we know that residual weakness in brachial plexus palsy. Earlier, it was thought that there is muscle imbalance. Certain muscles are recruited early and certain muscles are not. And because of that muscle imbalance, contractures and deformities happen. Although now a new concept is coming up that failure of elongation of degenerated or denervated muscle, meaning that those muscles who have not adequate nerve inputs, they get shortened. So that is a new concept. Of course, this is proven in animal studies, but this is by Roger Cornwall from Cincinnati. It's yet to see in the human studies, but that gives clarification of few things. Like, for instance, a C5-6 patient is developing interrotation contracture. Now, subscapularis has 70% input from C5-6, and if it is denervated, then why the child is developing contracture? Similarly, we see certain patients developing elbow flexion contracture in C5-6. Now, if biceps and brachialis are not working, why this happens? So this is the new concept, but we will have more information and a lot of research going on worldwide. For modify Mallet score, we check 5 main movements at the shoulder, and those are global external rotation, global abduction, hand to mouth, hand to occiput, and hand to spine. We'll take all these scores one by one. And then remember, Dr. Tejas will take your exam after this. He will ask you, okay? Now we'll ask randomly people to stand up. So now be very careful. If someone is sleeping beside you, usko utha do bhaiya. So modify Mallet score has 5 grade for each movement, where grade 1 is for no movement and grade 5 is for full movement. And so the minimum score would be 5 and maximum would be 25. So let's see the first thing. First, you ask the child to do sidewise abduction. Now, these are for the older children. Usually after 18 months, they follow your instruction. And if the abduction, there is no movement, that will be scored as grade 1. If the movement is less than 30, then it will be graded as 2. Between 30 and 90, it is graded as 3. And more than 90 is graded as 4. And of course, full movement is 5. So Anil, can you tell me why this segregation has been devised? Why less than 30, 30 to 19, more than 90? Yes, exactly. Very good. So this is glenohumeral dynamics, So first 30 degrees by supraspinatus, 30 to 90 is by deltoid, and beyond 90 is trapezius and serratus anterior. So this is how this score works. Then global external rotation. So you are asking child to turn the arm outwards. With arm is an adduction. So this way you do. And if it is less than 0, this is 0 degree. If it is less than 0, then the plot would be 2. If it is between 0 and 20, then it is plotted as 3. And if it is more than 20, then it's plotted as 4. So anyone, why this degrees 0 to 20, more than 20? Any idea? The reason is, if you see this range of motion and if you do the MRI of the shoulder, axial MRI, This range is correlating with a glenohumeral subluxation. When you have less than 0 degrees of passive external rotation, these shoulders are almost always subluxated behind. When it is between 0 and 20 degrees, the glenoid retroversion starts happening. And more than 20 degrees, there is usually a normal glenohumeral articulation. So this is global external rotation where it is done with the arm in adduction. The hand to neck is actually adduction. External rotation is done with the arm abducted. And if a child is not able to reach occiput, then it will be plotted as 2. It is reaching occiput, but with bit of difficulty. Child would scratch and slide the arm like this. Then it will be plotted as 3. And if it is easy, then it will be plotted as 4. Now we see in many children that they can reach occiput easily. But when we do this, they are scoring 4 here, but they are scoring only 2 here. So why is that? Why global external rotation is usually less than hand to neck movement? Shaktida, any clue? You're talking, okay. Ah. So when we are checking global external is why this eliminated gravity movement is lesser than against gravity. But the right answer is global external rotation is subscapularis on. Subscapularis pulls it and it's a restraint. But hand to neck is subscapularis off because their subscapularis stops acting. So that's the reason. So I think you have attended this CMEs. Oh, so Shakti, I mean, if there's repeated issues of this internet fluctuation, should we stop that live? Because then these delegates can attend it without any problem, because every few minutes it goes off. We need to have like the 5 GB persistent strong internet to relay it easily. Otherwise, ये लैपटॉप वहां ले लेना है. हाँ यहाँ yeah, the mic is there, no? So I can stand here. So it's important for you to see the slides and not me. So I'll now go in forward. That's not a problem. बैटरी तो अच्छा होगा. Let's hope. Sure. Yeah, column mic is. Yes, sir. Right. हाँ. So now this will come a nice view also. Now is a full screen, so you can see it better. और ये लाइट ऑफ कर दीजिए. हाँ. This will go perfect. Perfect. Good. Right. So now we don't need these lights, right? Because bus. तो वो public को कर दो. Yeah, perfect. So global external rotation, you are with me now, everyone? So global external rotation, when we check, we are checking external rotation in arm adducted where subscapularis is working. But when you do hand to neck, subscap is not working. And then that's why this movement can come. Now again that monitor needs to be brought down. See? So hand to spine is the fourth scope where we ask the child to take the hand behind the spine. And if child is not able to take it, then we plot it as 2. If child is able to take it but at the sacrum level, then it is 3. And if it goes to T12, then it is 4. And the last one of the fifth is the hand to mouth or trumpeting. When a child is asked to take the hand to mouth, we see if they have more than 80-degree elevation, then it is marked trumpeting, which will be plotted as 2. Between 40 and 80 degrees, it is 3, and less than 40 degrees as 4. So these 5 global Mallet score are there. And so we have a collective plotting like this. And typically your score will be like this. 12 out of 25. So if we do any shoulder rebalancing surgery, we will plot this on follow-up. So this can be used as an outcome measure or your indicator of what amount of improvement you have given to the child. Now, one movement which Dr. Scott Cousin, they devised that hand to belly function, hand to midline is also important function. When we are checking hand to spine, we are detecting 2 movement, internal rotation and shoulder extension. But when you have to reach midline for doing midline function like buttoning and zipping and all, you don't need to extend the elbow. And so the 6th score was added, and that score was hand to belly or internal rotation, wherein if you cannot touch at all, you are stuck here, you are not able to touch the tummy, then it will be plotted as 2. If you are touching your belly with wrist flexion, then it is 3. And you are able to touch with the arm fully flat, then it will be 4. So I'll show you some examples. So this baby is not able to touch the tummy, so it will be scored as 2. This child is touching with the wrist flexion, so it's 3. And this child is touching completely, and so it is termed as 4. Now this has a treatment implication that these children with a restricted hand to belly, they are the part of extended Erb's palsy. So this patient have C7 involvement, and it's an indirectly suggesting they have external rotation contracture and not the internal rotation contracture. And their treatment differs. Some of these patients would need arthroscopic posterior capsular release. Okay, so these are the Mallet score, and Tejas will now show you and we will ask you. So there are 6 scores now, and 6 score maximum can be 30, minimum will be 6. Anil, can you tell me which are the scores? The first one we check. So first one is global abduction, 30, 30 to 90 and more than 90. The second one was global external rotation, less than 0, 0 to 20 and more than 20. The third one was hand to neck, not possible, possible with difficulty and easily done. The fourth one was hand to mouth or hand to spine, yes. Fourth one was the hand to mouth. And hand to mouth 40, 40 to 80 and more than 80. That is trumpeting. And the last one was hand to belly. So child is not able to touch, touching with wrist flexion and touching with flat. So this kind of score you have to send to a treating doctor when a older child, more than 18 months child with shoulder problem comes. You should not refer कि sir कुछ shoulder में गड़बड़ है. No, you should refer that sir Mallet score is this, and child probably needs some shoulder balancing issue. So now Dr. Tejas will take your exam. So yeah, please. Yeah. So We also check movement of the opposite limb. And if they have identical range of motion easily done, then you can plot it 5. For elevation, they do not have any resistance. They don't use any trick movement. Then you can plot it 5. Okay, so Dr. Tejas will now randomly ask any one of you, okay, and you have to answer. Ready? Mike, how much?
So let's go to the demonstration of Mallet score. So the child is doing the global abduction for. So you can say that child is doing very good. Okay. So what will be the score for the global abduction? Grade 5, right? As good as the normal side. Now another child. It is for global abduction. What will be the score? Child is not able to do the global abduction more than 90 degree. What will be the score? It's 3, right? External rotation. Global external rotation. So it's difficult for her to bring the shoulder into more than 20 degree. So what will be the score? Yeah. Now, here I have kept my hand behind just to feel the contractions of the external rotator. So definitely it is not a complete flail limb. There is some movement at the external rotation. So what will be the score for the external rotation for this child? 2, correct. Hand to neck. 4. She's having little bit of, it is not as good as the normal side. Here, child is able to attempt the movement, but she is not able to do the movement, right? So, what will be the score? 2, correct. Hand to spine. She is able to reach at T12 level. So, what will be the score? T12, hand to spine. Correct. Hand to spine for another child. Hardly she reaches at the S1 level, right? Even S1 is also difficult for her.
2.
Correct. Hand to mouth. She's having very less trumpet sign, right? So what will be the score? 4. And for this child, she's having very marked trumpet sign, more than 80. So the score will be 2 for her. Hand to tummy, internal rotation. He's able to touch, but with a wrist flexion. So what will be the score? 3, correct. And he is able to touch without wrist flexion. Correct. Now, there are few more examples and I want everybody to participate, okay? Unfortunately, I am not able to run these videos. So anyway, we had a very good orientation about the what do you say Mallet score. Let me go to the another
Tejas,
set of.
there is one more child. You have Mallet score?
Yeah, no, I will be discussing the co-contraction now. So we can demonstrate the Mallet score. Yeah.
We have one older child who can follow our instructions, and then you can judge what malice score she has. Okay, come here. Come. Yeah. So if we can, so she has how uh, study- how old are you? Age क्या हो गया? 7 years, 8 years. Oh, God. She's 8 years old, so she certainly can follow our instructions. And we can see that she has left side affected, left extremity looks shorter, elbow is flexed. So let us start asking her to do the movement. पहले हाथ को ऐसे उठाना. Good, good. Very good. So she can abduct up to 90 degrees. उठाओ उसको. So a little bit more than 90. So what would you plot? Abduction, global abduction as 3. I would say it is 3, right? The next moment is global external rotation. So you keep it adducted. तो आपके बाहर लाओ बेटा. Yes, very good. Lao, 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 or. So it is just neutral. So 0. So what would you plot this external rotation as? So 2 is less than 0. Anything beyond 0 to 20 is 3 and more than 20 is 4. So you will plot it as a 3, yeah? 3. So this is global external rotation. Now let's see hand to mouth. So, so her trumpeting, if you look from the front, it is about 20 degrees. But this is a new concept, which we were to introduce in the later time. Now you look at on the normal side how she eats. Turn around. Now you eat with that hand. So you need a little bit of extension at shoulder and little bit of flexion, forward flexion here in order to reach to the mouth. And now look what is happening on this side. How so it is going up. So this we term as a forward trumpeting. And forward trumpeting is a sign of extended Erb's palsy or C7 involvement, which we'll discuss in details. But if we just see the coronal trumpeting, it is less than 20, so it can be plotted as 4, but she has around 45 degree of forward trumpet. Okay, now इसको सर के पीछे लेके. So she able to reach, but difficulty she is having. Let's see. Turn ऐसे हो जाओ. अभी सर के पीछे यहाँ चोटी पे लेके आओ. So she is doing external rotation, but she has difficulty in reaching behind, so it will be plotted as 3. It's not 4, it is 3. Yeah, very good. Now, what is meaning? Hand to spine. Okay, very good. Turn like this. And first, take this hand behind. ऐसा पीछे लेके जाओ. This one. पहले ये लेके जाओ. So she can take it up like this easily. Now put it down. और अभी ये लेके जाओ पीछे. So she is not able to. और लाओ पीछे. So she is doing a trick movement by giving a jerk, but she is not able to reach at T12. So it will be plotted as 2. And the child is not able to reach behind. You can check what is the amount of contracture she has. Now turn towards me. Usually when we abduct the arm at 90 degrees and flex the elbow at 90 and turn it like this, usually we can turn internally and there is no posterior capsular contracture. But these children turn around. Sometimes they have limited internal rotation, and that is a sign of posterior capsular contracture. She is about 10 degrees, not much. Okay. So, last, what malice score is remaining? Hand to belly. So, try to touch this hand like this. So, because she is having supination deformity, she is not able to do this, but otherwise she is touching her belly well. Okay. She has supination deformity, which is again we see in global palsy more frequently. And that's why she's touching this way, but I would score it as a 4. So her global Mallet you gathered, you should plot this way, and if you do some intervention, then you have to, in follow-up, you have to check what is happening in global Mallet. Okay, any questions about Mallet score? Great. So now you all are enriched with the why it happens. Right. They are now enriched with the classification. You know the Narakas types, you know the morphologic type, you know the quantitative assessment that HSCMS, and now you also aware of Mallet score. We will provide the literature to Dr. Prasad, and he will transfer it to you. And then you know for older children how to plot. So these are about Mallet score can be done even after 1 year if child is responding to your command. But usually after 18 months, they are able to do it. And then you can give some objects in order to catch that you can elicit those tests. Because there is no against gravity or against resistance movement, is unlike MRC grading. Now these scores are very important because here we are not inducing any resistance, but then the child will not show. And these are the tests which we will check even after nerve surgery for a pretty long time. Okay, so MRC gradings cannot be utilized in very young children. So these tests are very important. Mallet. So Mallet has a very good inter-observer reliability and inter-rater reliability as well. So what you need is child should be calm and not under stress. And then you can elicit movement with the toffee or the objects which they like, and they will very easily demonstrate. If child is in fear or anxiety, you can ask. We have a photograph of a fellow, all 6 photographs, and we send it, and they do the video recordings of photograph at home, and they bring it to us. And all the parents would like to have optimum record, optimum score, so they can give you that way. That's another way to do it. Okay, now one more important clinical examination thing which we all must know is a co-contraction. So brachial plexus, in the process of healing, there are aberrant innervation which leads to contraction of 2 group of muscles together, and that's known as co-contraction. And Dr. Tejas will take us through which are the common co-contractions. Okay. So ये हटा what side में perfect. Okay. So co-contractions. So co-contractions is contractions of 2 or more group of muscles at the same time due to the cross innervation. Tejas mic. Yeah.
Yeah. Due to the cross innervation, yeah, I can. ये चालू करो. Oh. Okay. So co-contractions is contractions among the 2 or more group of muscles at the same time due to the cross innervation while the healing process. Now, what are the common co-contractions? So the first common co-contractions is co-contractions is between the shoulder abduction and elbow flexion. Now, because of these co-contractions, you will see the body arm angle. Okay, and that is called the trumpet sign. Now, there are the different severity of trumpet sign. If it is more than 80 to 90 degree, it is a severe most. 40 to 80 is a moderate, and the less than 40 is a mild form of the trumpet sign. And we have also observed at our clinic that is a forward trumpet sign, and Dr. Maulin Shah has explained you what is the difference between the forward trumpet sign and the classical trumpet sign. Now, there are the different reason of the trumpet sign, and the first reason of trumpet sign is that the trumpet sign is because of the internal rotation contracture. Now, what happened? if child is having the internal rotation contracture because of the hand to mouth activity, okay, the child will land up into opposite side of the shoulder. Now to bring the food inside that mouth, they create the body arm angle. And this is the first reason of the trumpet sign. And this explanation is given by Dr. Howard Clark. The trumpet sign because of the internal rotation contracture. And this is the most commonest reason for trumpet sign. The second reason of trumpet sign is co-contractions between the deltoid and the biceps. Here you can see the child is able to do the external rotation with adduction very well, hand to neck activity. But when we tell her to do the hand to mouth activity, she co-contract both the muscles group together, deltoid as well as the biceps, and she create the trumpet sign. So this is the second reason of the trumpet sign. The third reason is the poor anti-gravity strength of the biceps. Okay, now the child who is having the poor strength of biceps against gravity, to bring something in their mouth, they abduct the shoulder, bring the elbow into eliminated gravity, and then they do the hand to mouth activity. So this is the third reason of having the trumpet sign. So these are the three reasons of trumpet sign. Now, the second most common co-contractions is among the shoulder abductors, elbow flexors, and the forearm flexors. Now, when we ask child to do the shoulder abductions, all three group of muscles fire together. And, it will be difficult for child to do the, individual movements. And it happens because of the cross innervation in between the deltoid, biceps, and long flexors of the muscles. The third common co-contractions is between the elbow flexions and extensors. It is difficult for child to do the hand to mouth activity. They stuck somewhere. And it is because of the cross innervation between the biceps and the triceps. And you can see on the surface EMG, both the muscles are firing together, biceps and triceps. The fourth common co-contractions is between the shoulder abductors and adductors. Now, it is because of the cross innervation between the deltoid and the pectoralis group of muscles. Here, the child will be having the difficulty in above head activity. And you can see the child is having, when they do the abduction, both the anterior and posterior wall of the axillary fold are dominant, you know, and the deltoid is also firing. So all the muscles are firing together. Now
Nice.
I will, yeah. Now I will ask to Dr. Nischal sir
You have any
to talk about.
now? That's okay.
Hmm.
So usually at this point we have a tea break because now that is the end of the session one. भाई अभी टी ब्रेक है नहीं पता नहीं है मुझे then Anil will tell you. But this is the end of the session one where we have uh, assessed the child. We have just examined. Now, can someone tell me that the girl we checked for Mallet score, which co-contraction she had? You remember, no? She was coming, she was doing like this. She had a bit of elbow flexion deformity, a bit of weak triceps. So this child had shoulder abduction and elbow flexion co-contraction. The moment you put an paddy wrap or elbow extension splint, their abduction would improve. So this sort of things you will observe in all the patients. So any question about assessment of these children so far? And if we don't have, then now we will embark on the treatment part, which you are interested to know. And we don't have any break now, right? We'll continue. Okay, so now we will talk about very important aspect of treatment, that is the indications and role of plastic neural reconstruction or brachial plexus reconstruction. Dr. Nischal will take us through that.
Uh, okay. Thank you.
Good afternoon. Leave. See, as we have discussed previously also, the decision making is based purely and purely on clinical examination. So that would be the core, and you have, just learned how to assess the child with Dr. Maulin and Dr. Tejas. And when, the limb is not moving as per our satisfaction, we can say that the child requires no surgery. Often we get radiological investigations done. More often, X-rays are to rule out any fracture that is associated with it. MRI is the commonest investigation that we do, but where you don't have a good facility of MRI, you can get EMG NCV done, which is also quite reliable investigation, but it is not going to guide you for decision making. It will only guide you what possibility you are going to encounter during surgery. So, if we go by Ellen Gilbas's criteria, you know, uh, if there is no biceps at 3 months, you go in and operate. Now it's very important to know no biceps. Flickers is biceps. No biceps means it's a flail biceps. But there is controversy. There are American doctors who wait for 6 to 9 months. Europeans and Taiwanese and Chinese doctors, they prefer to operate at 3 months. Nathi chaltu bapa. And for that, we have to revisit the JBJS data of Peter Waters, where out of 43 children who had zero biceps at 3 months, 38 of them, they recovered biceps at 6 months. So what would be any difference of outcome? Well, it's like, oh, yeah, we keep that one, so I would be better. So we have devised our way of decision making. Like if it is Narakas 1 and 2, then you wait for 3 months. Oh, but not feature. Click करने. Sorry, it has hanged. But if you know what is Narakas 1 and Narakas 2. So if there is no movement of biceps, totally flail shoulder and elbow muscles, then we think of surgery at 3 months. Otherwise, we wait for 6 months. At 6 months, if there is no biceps, we go ahead with surgery. If there is some power of biceps, we check for cookie test at 9 months. If child passes the cookie test, what is cookie test? We'll come to it. Then we don't require any nerve surgery. But if child fails the cookie test, then we go ahead with nerve surgery. In Narakas 3 and 4, we assess at 3 months. If there is flail hand with just flicker of movement at shoulder and elbow, we straight away go in and operate the child. If there is some movement of hand, shoulder, and elbow, we wait. At 6 months, if the progress is static, we don't wait for more time. We go in and operate at 6 months. But if there is progressive improvement of hand, elbow, and shoulder, we wait till 9 months. And at 9 months, we do the cookie test. To hold a cookie, you need to have good hand function. If child can bring that to mouth, then you don't need to operate for now surgery and you may have to go for secondary surgeries. So this is the cookie test. You give child a cookie, biscuit, wafer, anything. If they can bring it easily to mouth, then child passes the cookie test. And if child is not able to do it, then child fails the cookie test. Or, if child does any trick movement, uses the knee to push the elbow to mouth, or bends the torso more than 45 degrees, then the child fails the cookie test. So, how we operate, if we have got, I would say this is flail limb with a very rosy picture, where it is flail, but there are conducting neuromas in all the roots. Then it's little easier. You put the cable grafts and do anatomical reconstruction of brachial plexus. For suprascapular nerve, you can use nerve transfer. Now, if there is one root levels, two available, and lower trunk is intact, again it becomes little easier for us reconstructing it almost anatomically with C5 and C6 roots. And you may do spinal accessory to suprascapular if required. Now, more often than not in flail limb, we will have 2 or 3 roots avulsion. In that case, you have got C5, C6 roots or C5, C6, C7 roots. Your now transfer for shoulder reconstruction is important, and you put cable grafts and reconstruct from the available roots. Next. If there is single root, still, I have not got any case without any root. So going to opposite side of neck and taking partial root from opposite side has not been required in obstetric cases. In adult cases, we require it very often. But in pediatric cases, we can reconstruct shoulder and elbow with intercostal chest nerves and accessory nerve, and we give supply from that single root to all the trunks. Give more weighted to lower trunk when you are reconstructing, because you have already given intercostals for elbow flexion, you have given something for shoulder abduction, but yet you have not given anything for hand. So put maximum cable in lower trunk and then put few cables in middle trunk, and you put obviously some cables in upper trunk. Next. Now we have already discussed what are signs of root avulsion and multiple root avulsions. Those are the causes where you get bad results or poor prognosis. And Charlie, so multiple level injury, which is not there as such in obstetric palsy, it's more often in this adult brachial plexus injury. Those gives bad results. And late presentation, the commonest problem that we have in our part of the world, child will present very late. That is the cause of poor prognosis. Post-operatively and pre-operatively, the slings and splints are very important. Regular physiotherapy you have to do. Emotional rehab of the parents. When child is going to have a flail limb that child is born with, the parents will be very fragile. If you don't emotionally stabilize them and prepare them for realistic expectations and results, it's not going to work. I mean, till parents are not happy, your all the efforts are likely to go in vain. So when you open, when you do nerve surgery, everything looks like a nerve root. So you have to identify all the structures and reconstruct them. We prefer to use this nerve glue. Putting nerve glue helps you in one way, that you have to take minimum number of sutures with which you can oppose the nerves. So this is the first case, 4-month-old female, uh, full-term delivery, not a normal delivery. FTND means full-term normal delivery. This is not normal. This is forceps-assisted delivery with shoulder dystocia and right side Erb's palsy. So when you get an MRI done, these are the signs of avulsion. Pseudomeningocele is seen. There are so many fallacies. Pseudomeningocele means there is dural tear that is there. Doesn't necessarily mean the root is avul. So, it's almost 40% fallacies when we are uh, looking at MRI and their reports. And then you reconstruct with good cable graphs from the available nerve roots. And this is 1 year follow-up for that case. This is only thing you expect at 1 year. You don't expect dramatic recovery at 1 year. It takes a long time. And this child has also oops, sorry. Sorry. Sorry, I just pressed the wrong button. So at 1 year, shoulder and elbow movements will start. You are not going to see any hand movement at 1 year when you have operated at neck. Now regenerates at 1 millimeter per, day. That is the rate of regeneration, and there is stagnation of regeneration at all the anatomical repair sites that you have done. So for 2 months, practically there is no movement or no progression of regeneration. And this is the child on follow. She can use a good hand function. Getting a normal hand function in opsadic palsy flail limb is, very less often that you see. There is another 1.5-year-old female child recovering with shoulder function, but there is no active elbow flexion. Whenever you try to check for elbow flexion, she was using the knee joint and doing trick movements. In this case, we have done Oberlin transfer for elbow flexion. That is, you take ulnar and median nerve part of it and repair it with musculocutaneous nerve. So this is how you isolate the nerves. Take the branch of biceps and brachialis muscles. There are two muscles that do elbow flexion. Elbow flexion with supination is done by biceps, and brachialis, which does only elbow flexion, whether it is supination or pronation. And this is 1 year post-op follow-up. Good bulk of biceps is there in this child. And supination takes little longer time to come as compared to the elbow flexion. Elbow flexion starts, supination starts after that. This third case, 2-month-old baby, when we received 4.5 kg of birth weight, there was Horner's, and we have plotted HSCAMS, and you can see at 4 months, there is no external rotation, hardly any abduction, no elbow flexion, and no supination. The limb is like that. There is some movement of finger and wrist flexion. Otherwise, there is almost no movement. So we reconstructed it. There was a long distance gap. So taking both sural nerves, we could put in only 5 cables to that. Nowadays, given a choice, I take even medial cutaneous nerve of arm and forearm from elbow till shoulder. This is long-term result, good shoulder function, good elbow. There is some amount of trumpeting that is there, good hand to head, there's good hand flexion and extension, but you can see child is not able to supinate. There is little bit of pronation that is there. Wrist extension. After that, we had done even osteotomy for supination, forearm osteotomy, and wrist has over period of time recovered to normal. So now child can even play cricket very easily with his own self. I mean, so to sum it up, 70% of patients have recovered power grade 4 in hand, wrist, and elbow. 30% had poor results. These are cases where 3 and 4 roots were levels, and 3 patients required shoulder rebalancing surgery after that. 1 patient, as I had shown in my first presentation, had diaphragmatic paralysis. Recently, I faced a second child who had diaphragmatic paralysis. These children have to be sent to pediatric ICU for a couple of days. If they don't recover, if they persist for a week or more, it's important that you get a pediatric surgeon and get diaphragmatic plication done, which helps the child. Otherwise, lungs would start collapsing on that side. And post-operative management that we do is we mobilize for 1 month. After 1 month, we start physiotherapy, ultrasound or local gentle massaging for releasing the scar. Electrical stimulation is started after 1 month. We don't get repeat investigations as a routine in all these patients. But if at all required, you can get a repeat nerve conduction study, not EMG, because muscles are not going to start firing. But whether nerve is progressing beyond your repair or not, you can check with nerve conduction studies. So to conclude, timely intervention in panplexopathy is the crux of getting good results. And most of these patients will have some movement deficit and they will require secondary surgeries. So now surgery forms a perfect platform for future of the child. If at all later on child has some residual hand, elbow or shoulder deformities, we'll be discussing all those things. then you may need all those surgeries later on. But if now surgery has not been done, your progression to that stage will never happen. Thank you. Any questions? Sir.
Hello.
Okay, I am Professor Arun Chaudhary. I am the ex-professor HOD of Plastic Surgery, SU Medical College, Cuttack. My question is, sir, in this neuroplexy, or you can say nerve transfers, or even you have done interpretation of graftings. Uh, in children, in adults, we have a lot of exposure experiences. Children, when you go for a free functional muscle transfer,
Sir, even after 2 years, if child doesn't have any elbow flexion, then we start preparing the parents. We prefer to wait till 5 years before we go for, free muscle transfer. People do it at 2 or 2.5 years.
so what is your experience with the children and their prognostic value in
Sir,
doing a
with
free
God's
muscle?
grace, we required only 3 patients so far who had to undergo free functional muscle transfer for elbow flexion. We could not, we did not require it for hand function because again, you can extend it till forearm muscles to get some amount of cross hand functions, but all those patients had some amount of function. Of those 3 patients, uh, they've got great free power. We had to take intercostals with that because all the nerves in neck were exhausted. And obviously, chest physiotherapy and deep breathing exercises to be advised for at least 1 year is very important when we are doing free gracilis with intercostal nerves.
Thank you very much for your nice presentation, sir.
Thank you.
Thank
Sir.
you.
Hello. Hello.
Jai Jagannath. Good afternoon to all the respected dignitaries, faculty members, distinguished guests, healthcare professionals, and dear student. I am Muskan Jha, a third year student from Bachelor's of Physiotherapy, and I, Shikha Mohanty, also a third year student from Bachelor's of Physiotherapy. Welcome you all. It is indeed a great honor and joy to stand before you today as we gather here for a much awaited and intellectually enriching seminar come hands-on workshop on current concepts in management of brachial plexus birth injury, organized by School of Occupational and Physiotherapy, DRIEMS University, in association with India Orthopedic Association, Odisha Orthopedic Association, and Pediatric Orthopedic Society of Odisha. Before we begin, let's take a moment to acknowledge the reason we all are here today. To deepen our knowledge, sharpen our clinical skills, gain insights into one of the most intricate areas of neuromusculoskeletal care. This workshop brings together expert mind, passionate learners, and dedicated clinicians to explore the current practices, challenges, and advancement in the diagnosis, treatment, and rehabilitation of current practices. Whether you are a student, a healthcare professional, or someone passionate about neurorehabilitation, we hope today leaves you feel informed, inspired, and empowered. We are privileged to have you all with us today. So let's gear up for a day filled with learning, hands on discussion, real case studies, and of course, a lot of questions and interaction. As we stand at the threshold of this enlightening academic session, it is only fitting that we begin with the symbol of wisdom, clarity, and learning. To mark the auspicious beginning of our event, we now invite our dignitaries to come forward for the light lamping ceremony, a symbol of knowledge, wisdom, and enlightenment, and our respective faculty members to join us on stage. We request to audience to please rise and join us in showing respect as we evoke this moment of tradition and hope. Please, sir. Volunteers, please assist them. We thank our dignitaries for gracing the stage and lighting the way ahead for all of us. Let this flame inspire us throughout today's session. Now, moving ahead, it's our privilege to welcome the most awaited personalities of today's event onto the dais. So, now I request Dr. Pramod Chandra Rath sir, Chairman DRIEMS University, Professor Dr. Prakash Kumar Hota sir, Vice Chancellor DRIEMS University, Dr. Kanhei Ram Mahapatra sir, President of Odisha Orthopedic Association, Dr. Durga Prasad sir, Dean School of Occupational and Physiotherapy, Dr. Maulin Shah sir, consultant pediatric orthopedic surgeon, specialization in brachial plexus injury in children, Dr. R.N. Mahanti sir, president of Pediatric Orthopedic Society of Orissa, Dr. Shakti Prasad Das sir, member of Board of Director, DRIEMS University, to kindly come upon the stage and take their respective seats. Volunteers kindly assist them. To honor our esteemed guest, we will now present badges and bouquets as a token of respect and gratitude. So, volunteers, please. Thank you so much. May I now take the honor of inviting our esteemed Dean, School of Occupational and Physiotherapy, Dr. Durga Prasad Mishra sir, to kindly come forward and deliver the guest address. Sir, please.
Good afternoon, everyone. It is my privilege for giving this welcome address. Respected Chairman Dr. Pramod Chandra sir, Honorable Vice Chancellor Professor Prakash Kumar Hota sir, Registrar Bhaktacharan Pradhan sir, and Dr. R.N. Mahanti sir, Dr. Kanhira Mahapatra sir, Professor Shakti Prasad Das sir, our esteemed dignitaries on the dais and in the audience, revered national faculties, distinguished delegates, dear faculty members, students and guests. A very good afternoon and warm welcome to one and all. It is both my privilege and honor to stand before this distinguished gathering as the Dean of the School of Occupational and Physiotherapy, DRIEMS University, and extend a heartfelt welcome to each one of you on this momentous occasion, the National Seminar come hands-on workshop on current concepts in management of brachial plexus birth injury. Today marks a significant milestone in the academic journey of DREAMS University as we bring together some of the finest minds in the field of pediatric orthopedics, plastic and reconstructive surgery, and neurorehabilitations. This workshop is not just an academic congregation but a vibrant confluence of surgical excellence and therapeutic innovations, reflecting our institution's commitment to interdisciplinary education and patient-centric care. Brachial plexus birth injuries, though rare, pose profound challenges, not just to surgeons, but to the entire continuum of care. The impact spans from operating theatre to the rehabilitation room, from the anxiety of parents to the perseverance of therapists, from the vulnerability of newborn to the resilience of science. And it is the continuum of care, this collaborative philosophy that we aim to strengthen through today's deliberations. We are deeply honored by the gracious presence of our chief guest, Dr. Pramchand Rath sir, whose unwavering vision has been a beacon for academic and clinical excellence at DREAMS. I extend my warm welcome to all our dignitaries and thank you for your constant encouragement and support, sir. I also take this moment to express my heartfelt gratitude to our distinguished national faculties, Dr. Maulin Shah, Dr. Nischal Naik, and Dr. Tejas Patel for joining us and sharing their invaluable expertise in this highly specialized domain. Their presence ensure that this workshop will be a transformational learning experience, especially for our young clinicians and rehabilitation specialists. This event is the result of synergistic collaboration between School of Occupational and Physiotherapy, Dreams University, Department of Orthopedics, our esteemed partners like Indian Orthopedic Association, Odisha Orthopedic Association, and the Pediatric Orthopedic Society of Odisha. My heartfelt thanks to all of them for their unstinting support and shared visions. A special word of appreciation for the organizing team, our dynamic faculty, dedicated staff, enthusiastic students who work tirelessly to bring this workshop to life, the precision, discipline, and devotions. To all our participants who have traveled from various parts of the country, welcome to Odisha and welcome to Dreams. May your time here be intellectually enriching and professionally rewarding. Let us together make today not just a day of learning, but a day of collaboration, commitment, compassionate care. As we unite to give hope, healing, function back to the tiniest hand that deserve to move, hold, and embrace life. Once again, I extend a warm welcome and wish the program a grand success. Thank you all. Jain. I also welcome to all the media personnel present here for their gracious presence. We welcome them with our heartfelt gratitude. Thank you.
Thank you so much, sir. With great pride and profound respect, I take this opportunity to welcome a highly esteemed guest, Dr. Arin Mahanti, sir, the President of Pediatric Orthopedic Society of Odisha, to this significant academic gathering. His leadership in the Pediatric Orthopedic Society of Odisha has helped bridge gaps between clinical excellence, community outreach, ensuring that young patients receive not only the best care but also early intervention and long term support. We now request you, sir, to kindly come forward and share a few words with the audience. Please, sir.
Good morning. So dignitaries on the dais and of the dais, and students, delegates, and mm, faculties coming from outside. I welcome you all to this event, the brachial plexus injury, and how we are here to learn from the masters of this injury. So let us see how we are going to be benefited by this. So we are very much thankful to Dreams organization for arranging this brachial plexus injury, which is a very, very common but neglected thing in our part of state or country. And that's why very few personalities or very few specialists are there in India to deal with that. And we have got the best of the things, Dr. Maulin Shah and his team from Ahmedabad. Let us welcome them with a greeting, a lot of clapping. So what I have observed that though Pediatric Orthopedic Society of Odisha is very nascent in origin, we are only say this is our second year of organizing any conference or say workshop. So, but we are progressing very fast, and we hope by the end of this session we will be dealing with this brachial plexus injury in this part of country, and we will learn a lot. And thank you all the delegates and also the Dreams organization for giving us the opportunity to organize this event. Thank you.
Thank you so much, sir. Now it's a great honor and privilege to welcome a visionary leader, an academician of high repute, and the guiding force behind the growth and excellence of our institution, our respected Vice Chancellor, Professor Prakash Kumar Hota, sir. Sir, please, we now humbly invite you to the stage.
Good morning to all of you. Honorable Chairman, Dreams University,
all the dignitary of the dais, and particularly the resource persons invited from Ahmedabad and his team, all the faculty members, all the doctors coming from different parts of India, students, and the electronic and print media persons. First of all, as the Vice Chancellor of this university, I welcome to this university for this great purpose. Yesterday, when the Sakti sir and the dean, they invited me. First of all, the curiosity was with me that what exactly the topic is. Being the technocrat, being the educated person also, we don't have much idea. That means this is such a thing or such an important topic. A great awareness program has to be there. We do not know. Then what about the people staying in the villages and all? So a campaign of this kind of awareness has to be done. In addition to that, being a university offering multidisciplinary courses, our job is that the traditional classroom teaching has to be transformed into the experiential learning. And this is the right direction the department or the School of Physiotherapy and Occupational Therapy is going. It is not strange thing. It is the regular feature of this department, this school, as well as the university. We always promote this kind of platform to promote the experiential learning. Experiential learning, a common man can understand. The students, the faculty members, everybody should learn through the experimentation. I am today fascinated when our Ahmedabad team, the doctors, they demonstrated. Being an engineer, I could able to take what exactly this was. I came to know that within this 1 or 2 hours learning, I could able to know that this is a birth injury. Some sort of knobs are getting damaged, which are connected in between the arms as well as the spinal cord. When you're talking about the spinal cord, it's most dangerous thing. It should not be hampered. So what is the implication? If it is not detected earlier, then long-term consequences are very much vital. Most importantly, the movement will be reduced, the gripping power will be reduced. These are the other things, physical things. A child, when he'll be growing up, he can sustain all those things. But what about the mental agony? That means the long-term implication, everybody should understand that. If it will not be taken care of at the right time, then his self-esteem of the child will be imbalanced. Then lot of other things will occur. So this is the right platform where everybody will be getting some knowledge and try to dissipate. All the participants I'm talking in large, whatever information, whatever knowledge you are gathering here, you should dissipate. Because the teaching learning processes, this will improve in any university, provided that research in a particular direction has to be carried out. Because research can enrich, can inform the teaching process. Students, if you know better things, then they'll visualize, they can do miracle in future. On the other hand, teachings also, it helps the research. What it does, teaching can stimulate research. Just doctors are doing right now. All those doctors, all the health professionals, they can strengthen, they can give some new direction to the student that our teaching methods should be such that in future we can do this kind of thing. I am very happy that whatever demonstration, physical demonstration, I hope some video demonstration will be there. That is also not enough. Don't stay there. You think beyond that. Our technology is evolving in such a way that what miraculous thing can happen. You see, India is progressing in that direction. I'm sure if everybody will put their effort, India is not far away. In medical science also, it will be number one also. So I'm talking about machine learning, artificial intelligence, data analytics. Very simple example is that doctors, they're having lot of patients data, clinical data, all those things are there. From different institutes data also they can accumulate. Now just imagine if a AI platform, if a data analytics platform will be installed here, some new informed decisions can be taken by the doctor, will not only help our students, our hospital, we can also advise the correct direction to the other hospitals across the state, particularly local environment, as well as in the nation. I don't want to tell much of the things. I am very privileged. I am very proud that this school is doing this kind of thing. Thank you all for giving me this opportunity.
Thank you so much, sir. Now, I invite a highly respected figure in the field of orthopedic, the president of Orissa Orthopedic Association, Dr. Kanhai Ram Mahapatra, sir. Sir has been a pioneer in the orthopedic care, education in our state, and his dedication to the advancement of clinical excellence and knowledge sharing is truly inspiring. So, we are deeply grateful to have him with us. Please, sir.
Good afternoon, all. A warm greetings from Odisha Orthopedic Association. It is a great pleasure here to welcome all of you. And I am seeing a lot of physiotherapy and occupational students are there. I wish my PGs, especially this orthopedic PGs should be there to learn this beautiful subject. This subject, which is usually overlooked in undergraduate and postgraduate career of medicines, and it is even underemphasized in clinical practice also. My sincere thanks to the OSO leadership and all the faculties who are here and for their beautiful demonstration and beautiful topics they are chosen for this CME. My sincere thanks to all the organizers, the DRIEMS hospitality, and the students also for the learning process. Let the learning process be fruitful, and I wish all success. Thank you. Thank you very much.
Now, it's a pleasure to invite a key person behind the planning and execution of today's workshop, Dr. Maulin Shah, sir, our respected course coordinator. Sir, your dedication, precision, and tireless effort in shaping the academic structure of this program have been truly commendable. Your vision has played a pivotal role in bringing together experts, learners, and meaningful dialogue in today's session. We now request you to kindly come forward and address the gathering. Please, sir.
Thank you very much. They give such lovely introduction, no? So that AI has helped there also, Chat GPT. I would like to share one experience. I was a clinical fellow at Hospital for Sick Children, Toronto, in year 2008-9. And at that time, one of my professor was Dr. William Cole. And William Cole was a researcher and originator of Cole gene in osteogenesis imperfecta. And he was instrumental in testing bisphosphonate to improve the bone mineral density in these children where the bones are brittle and weak. And so I got that knowledge that these patients can be injected this drug and we can reduce the rate of fracture and the pain and so on. And the moment I finished my fellowship program, I came back to Ahmedabad. And as a beginner, you do a lot of outreach clinic, right? And so I did my first outreach clinic in a place known as Bhavnagar. It's on the in the coast with the north and west to Ahmedabad. And there was a patient coming 300 kilometers further far from a village, and he was suffering from osteogenesis imperfecta. So, in 1 month, the knowledge which was dissipated, generated from Toronto, in 1 month, it reached to a remote village of Bhavnagar district. And I was the one who could pass it. I'll be equally happy today if one of you reach to a remote place of Odisha and you treat the patients of obstetric brachial plexus palsy in a way we are examining and we are
getting. So that is the key message or key aim of us, me, Nischal and Tejas. It is 20th CME we are doing in different parts of India and Asian countries being Bangladesh or Sri Lanka. Our aim is to teach everyone how to evaluate properly and how to give timely treatment, because we cannot expect these patients to come down to the center where this quality of care is given. So it's our duty to educate each and every person who is keen in treating them. And there's a huge burden, the incidence of brachial plexus birth palsy is a little lesser than clubfoot. And so we are leading to very high number of patients, and rightly said by sir that if they are not well treated, they undergo a lot of social issues, their psychological performances, then non-acceptance at various places. And I'm a writer also. I'm an author. I've written few books, so I know I go into deep into sentiments of these patients. So it's a huge responsibility for all of you. Now, by sparing one Sunday, it's actually a responsible thing which you can do and cater to this patients in this region. And we have a huge responsibility to take care of these needy children. So I am thankful that you have spared your Sunday, and I'm very impressed by the talk by all the dignitaries. Usually dignitaries they talk monotonously, but I was keenly listening to them, and I'm very happy and inspired. Thank you very much.
Thank you so much, sir, for your warm and insightful words. Coming to the next, I take this opportunity to welcome Dr. Arun Chaudhary, sir, Senior Plastic Surgeon. Sir, your years of dedicated service, clinical excellence, and contribution to plastic surgery have touched many lives and inspired countless students. Please, sir.
Jai Jagannath. At the outset, I must warm welcome our dignitary on the dais, Dr. Shah, Dr. Naik, and Dr. Patel on the dais. I mean, on of the dais. We are very much really privileged and proud that such dignitary of a national level has given the consent to come over here to this institution. And they have been doing a great job from the morning. I have not come as a faculty, but I came as a student to learn if new things has happened and I didn't know. So a lot of new things, and I always feel like any professional should be a student all the life, because that makes you a difference, that you learn new things. So this was my conception when I came in the morning, and it was only possible when Dr. Sakti Das told me, sir, why don't you join with us? Yes, dream is a really dream. In fact, my daughter-in-law was reading engineering here long back. So I had little affinity for this institution and I have attended few. So dream is something, really it is your dream of life also. So it is led by the leader. To have a big leader like Mr. P.K. Rath, Pramod Kumar Rath, when he introduced, I am Pramod Kumar Rath. Uncle, you don't need introduction, sir. Everybody in Odisha and around knows you. And your works tell what greatness you have done for this institution. And most important for any of the engineers or any professional doctors, they can be a very good surgeon, very good physician, or very good engineer. But to be an engineer or a professional with an enterprising mindset and with a big vision for future are very few, and that too in Orissa. So that what he has, and his visions are very strong, very good. And I remember when I went for a WHO fellowship to Australia in Sydney in John Hunter's hospital, when I saw the helicopters are landing with patients on top of the hospital and on the ground there were two helipads. Then same thing when I came to India and when I was the nodal officer for trauma and burns to Government of India, when I told in the Government of India meeting of the all states, including the health secretary, and one time the minister was also chairing, they told it is possible in India. Why not? India can do many things in future. It all requires. because trauma and accident, road traffic accident, so good in our country, good in the sense, so many patients are dying out of it. And we do not have that system of golden hours. And now coming to the point of brachial plexus birth injuries. To my experience of 3 decades, I was talking to Dr. Shah that I might have operated more than 200 brachial plexus in adults, but I have only seen 4 cases of birth injuries. So the reason being, you just see, here I saw 4 cases one day in one time. The reason being that lot of sensitization of patients, doctors even, where the patient has to be treated by a well set up like they have made it in Ahmedabad. So a team of doctors is required to give the best treatment. So see, problem with it, we doctors, we are very much egoistic. If I'm plastic surgeon, I tell I know everything. If an orthopedic surgeon, he tell I know everything. A neurosurgeon will tell if I know the brain, whole body is mine. So like that type of some ego always plays. But people like were really sensitive, like I told you, the team of 3 people who have come. I have seen some other team in Coimbatore also, Ganga Hospital. So wherever there is a team and the work is very important on the quality is concerned. So I am not going to have a big speech on this, but the quality of work they have been doing there and they have presented it from the fundamental level. I always tell the students, we may be a physiotherapist because occupational therapists, physiotherapists, even postgraduate, they have done thesis under me. And fortunately, I was lucky enough to have 30 MCA students have passed out. One of the student of mine is also there in DRIEMS now, continuing in plastic surgery, Dr. Mahapatra Chandan. So out of that 4, I've been heading 4 AIMS of the country, including Bhubaneswar AIMS. So they have the advantage of the Professor Hota was talking now. They are the advantage and privilege to have AI, robotic, and what GPR chart and all that. So now the young age groups have the advantage of getting the technology, digitalization, and availability of all these newer gadgets. If they impregnate and they can do a great work in the all over world, not of India I'm talking of. It is possible. And we have shown in war, last war also, how technically we are so sound and we can go to achieve any heights. So this is unique in the sense, I think to my knowledge, I have done of brachial plexus, live operative and other that. This is the first workshop on brachial plexus birth injury in the state. So doing first time is more very important because it remains as a milestone. I believe in it. So even though it is not my experience on this is very less, still I came to learn here. And I think it is a mixture of plastic surgeon, not only the orthopedic surgeons, as Dr. Shah is an orthopedic surgeon, so is a great help for us. Even the most important is a physiotherapist. So their involvement are very, very important. I think if you can have a team, then you can really justice to the patients. I believe to be a good surgeon, mostly for the young people, you should have A, B, C, D. A means attitude. First is to learn. That should be your attitude. You should be available. A is for availability. As a good doctor, you should be available whenever you are called for in emergency, whatever status you may be. Third is second is your B. B do not require anything, money. That is your behavior. You have to behave everybody. Patient is your God. It is not Jagannath. It is the patient. You have the privilege of getting that faith of the patient to come to you. Everybody don't go to every doctor. So if somebody has come to DRIEMS, then he has a faith on DRIEMS, and you have the responsibility and moral responsibility mostly to deliver the best possible treatment. C is your competence. You see, without being competent in your profession, you cannot go further. That has to be developed and you have to update. D. D is demand. What is the demand? Patient, you don't demand, patient demands. So there comes the philanthropic work, which Mr. P.K. Rath will understand what is a philanthropic work. So mostly he must be maintaining things in such a way that most of the poorest of the poor people must be getting benefit. Then what they give you then? They give you the blessings. How they give you blessings? Their blessing comes through God, Lord Jagannath. So these are all, I am not talking of health is defined as physical, mental, they add now spiritual. And yesterday, International Yoga Day, 11th anniversary of the Yoga Day has been celebrated. So these are now today's world. It is not of anybody individual. It is a collective thing to be developed. I think with that note, I hope this institution has a big future because the vision of the key persons here are much more ahead. And the students who pass out, they should feel proud working anywhere in the country and abroad that we have been from Dreams. And these type of workshops give a tremendous knowledge which cannot be weighed by anything else. And for that, the persons behind the scene, the organizers, must have taken a lot of pain, strain, and sleepless night to organize this. Because I was talking with Dr. Das many a times, are you having this, sir? Many a times people do cancel at the last hour due to some reasons. And I learned that this is going through YouTube. So this is another advancement of this institution, that not only you keep the knowledge inside this hall, it goes beyond the hall and lot of people will know. So ଏଇଥିରେ ମୁଁ ଆପଣମାନଙ୍କୁ ସମସ୍ତଙ୍କୁ ମୁଁ ଆନ୍ତରିକ ଧନ୍ୟବାଦ ଦଉଛି। ଆଉ ମୁଁ ଏ ଭାବୁଛି ମତେ ଯୋଉ ଡାକିଛନ୍ତି ସେଥିପାଇଁ ମୁଁ ଆଜି ମୋର ଏଇ ସମୟ ଆଉ ଏଇ ଇଏରେ ମୁଁ ଏତେଟା ସମ୍ମାନ ପାଇଲି, ସେଥିପାଇଁ ମୁଁ ସମସ୍ତଙ୍କୁ କୃତଜ୍ଞ। ଧନ୍ୟବାଦ। ଜୟ ଜଗନ୍ନାଥ।
Thank you so much, sir. Now, we have reached a very special and heartfelt part of today's event, the felicitation ceremony. It is our humble tradition to express our deep gratitude and appreciation to the dignitaries and experts who have taken time out of their valuable schedules to be with us today. Their presence, guidance, and words have truly enriched this academic gathering. We request Dr. Pramod Chandra Sir, Chairman Dreams University, to kindly come forward and do the felicitation ceremony. Please, sir. So now let's begin with Dr. Maulin Shah Sir, Consultant Pediatric Orthopedic Surgeon and specialization in brachial plexus injury in children. Volunteers, please come forward. Thank you, sir. Next, we have Dr. Nischal Naik, sir, consultant brachial plexus and peripheral nerve surgeon with vast experience in brachial plexus injury in children. Sir, please. Next, we have Dr. Tejas Patel, sir, pediatric physiotherapist and pediatric aquatic therapist. Sir, please. Next, we have Professor Dr. Prakash Kumar Hota, sir, Vice Chancellor, Dreams University. Volunteers, please come forward. Next, we have Dr. Kanhiram Mahapatra sir, President of Odisha Orthopedic Association. Volunteers, please come forward. Next, we have Dr. R.N. Mohanty sir, President of Pediatric Orthopedic Society of Odisha. Next, we have Dr. Shakti Prasad Das sir, Member of Board of Director, DRIEMS University. Next, we have Dr. Durga Prasad Mishra sir, Dean School of Occupational and Physiotherapy. Volunteers, please come forward. Next, we have Dr. Jyoti Ranjan Sahu sir, Assistant Professor, School of Occupational and Physiotherapy. Next, we have Dr. Ashiva Das sir, Assistant Professor, HOD School of Occupational and Physiotherapy. Next, we have Mr. Ninakar Sahu sir, Public Relation Officer, DREAMS University. Sir, please. Okay, Sahu sir, HOD Hospital. Next, we have Dr. Arun Chaudhary sir, Senior Plastic Surgeon, ex-Medical College. Sir, please. So next we have Dr. P.K. Sahu sir, HOD PMR, Esvinitar Olotpur. Sir, please. And next we have Dr. Anil Panda sir, Orthopedic Surgeon, High Tech Hospital, Bhubaneswar. Sir, please. Chairman. Now we move forward to a moment of great honor. I request our guest, Dr. Kanhim Ram Mahapatra, sir, President of Odisha Orthopedic Association, Dr. Maulin Shah, sir, course coordinator, Professor Satyaranjan Patra, sir, Secretary of Odisha Orthopedic Association, Dr. R.N. Mahanti, sir, President of Pediatric Orthopedic Society of Odisha, to kindly felicitate our Honorable Chairman, sir.
Thank you so much, everyone. Now, it's with great respect and privilege that I take this opportunity to welcome our visionary leader, our dedicated academician, and a guiding force behind today's event, our chairman, Dr. Pramod Chandra Rath, sir. Sir, your unwavering commitment to education excellence, institutional growth.
ଆଜିର ଏ ୱାର୍କସପ୍ ସେମିନାରରେ ବାହାରୁ ଆସିଥିବା ସମସ୍ତ ଡକ୍ଟରଙ୍କୁ ମୁଁ ନମସ୍କାର କରୁଛି। ସେମାନଙ୍କୁ ବହୁତ ସଦିଚ୍ଛା ଜଣାଉଛି ଯେ ସେମାନେ ଡ୍ରିମ୍ସ ଇନଷ୍ଟିଚ୍ୟୁଟକୁ ଆସିକିରି ଆମକୁ ବହୁତ ଗର୍ବିତ କରିଛନ୍ତି ବୋଲି ମୁଁ ଭାବୁଛି। ଲାଷ୍ଟରେ ପ୍ରଫେସର ଚୌଧୁରୀ କହୁଥିଲେ ଯେ ପିଲାମାନେ ଆମର ସମସ୍ତେ ଜାଣିଥିବା ଦରକାର ଯେ ଆମେ ଯୋଉ ସବଜେକ୍ଟଟାକୁ ଏଠି ଡିସପ୍ଲେ କଲେ, ଡକ୍ଟର ଶାହାଙ୍କର ବି ମୁଁ ଶୁଣୁଥିଲି, ବାଇଟ୍ ବି ଶୁଣୁଥିଲି ବାହାରେ, ତାଙ୍କର ଫ୍ରେଣ୍ଡସ୍ ମାନେ ଆସିଛନ୍ତି, ଅଲ୍ ଡକ୍ଟର୍ସ ଫ୍ରମ୍ ଡିଫରେଣ୍ଟ ଷ୍ଟେଟ୍ ଓ ଡ୍ରିମ୍ସକୁ ଆସିଥିବା ସବୁ ଆମ ଷ୍ଟେଟର ଯେତେ ମେଡିକାଲ କଲେଜ ଅଛି, ଫିଜିଓଥେରାପି ସେଣ୍ଟର ଅଛି, ସମସ୍ତଙ୍କୁ ବହୁତ ବହୁତ ବଧାଇ ଦଉଛି। ଏଠି ଆକ୍ଚୁଆଲି ମୋର କହିବାର ବେଶୀ ଅବକାଶ ନାହିଁ, କାରଣ ଏଇଟା ଗୋଟେ ଟେକ୍ନିକାଲ ସବଜେକ୍ଟ। ଟେକ୍ନିକାଲ ସବଜେକ୍ଟରେ ମୁଁ ଯେତିକି ବୁଝୁଛି, ଯୋଉ ଟେକ୍ନୋଲୋଜି କି ନେଇକିରି ଆମେ କାମ କରିବା ସେ ବିଷୟରେ ଡକ୍ଟର୍ସ ମାନେ ବେଟର ଆପଣ ମାନଙ୍କୁ ବୁଝେଇବେ, ମୋ ପିଲାମାନଙ୍କୁ ବୁଝେଇବେ, ଯୋଉଥିରେ କି ପିଲାମାନେ ଏଜୁକେଟେଡ ହେଲେ ସେମାନେ ଭଲ କରିବେ। ଡକ୍ଟର ଶାହା ଜଷ୍ଟ ଇଣ୍ଟ୍ରୋଡ୍ୟୁସନରେ କହୁଥିଲେ ଯେ ମୁଁ ଯେତେବେଳେ ଫେଲୋସିପ୍ କରିକିରି ଆସିଲି, ମୁଁ ଗୋଟେ ଗାଁର 300 କିଲୋମିଟର ଦୂରରୁ ଗୋଟେ ପେସେଣ୍ଟକୁ ଆସିଲା ପରେ ମୁଁ ତାକୁ ଯୋଉ ପ୍ରକାର ଦେଖିଲି ଆଉ ଯାହା ଇଏ କଲି, ତାର ଏକ୍ସପିରିଏନ୍ସଟା ହଉଛି ତାଙ୍କର ଅଭିଜ୍ଞତା। ସେଇଟାକୁ ନେଇକିରି ସେ ଆଜି ଏତେ ବଡ ଲେବୁଲରେ ପହଞ୍ଚନ୍ତି। ଯୋଉମାନେ ଆଜି ଆସିକିରି ଏଠି ଅଛନ୍ତି ସେମାନେ ଡେଫିନେଟଲି ଗୋଟେ ଗୋଟେ ବଡ ହାଇ ଲେବୁଲର ପର୍ସନାଲ। ହାଇ ଲେବୁଲର ପର୍ସନାଲ ର ମିନିଂ ହଉଛି ସେମାନେ ଯେତେ ଉପରକୁ ଯିବେ ସେତେ ନଇଁ ଯିବେ, ଯୋଉଟା କି ମୁଁ ସମସ୍ତଙ୍କ ପାଖରେ ଦେଖିଲି ତାଙ୍କର ଇଗୋଟା ନାହିଁ। ପ୍ରଥମ ଡକ୍ଟର ଚୌଧୁରୀ କହିଲେ ଆମେ ଡାକ୍ତର ହେଇଗଲେ ଭାବୁ ଯେ ମୁଁ ସବୁ ଜାଣିଛି, କାରଣ ମୁଁ ଜଣେ ଏଇ ସବଜେକ୍ଟରେ ବହୁତ ଏକ ଅଛି। ସମସ୍ତଙ୍କର କିଛି ନା କିଛି ଶିଖିବାର ଲାଷ୍ଟ ଏଣ୍ଡରେ ମଧ୍ୟ ଶିଖିବାର ଅଛି। କାରଣ ମୁଁ ଜଣେ ଡକ୍ଟର କେସି ସାହୁ ଆମର ଜଣେ ଡାଇରେକ୍ଟର ଥିଲେ, ସେ ଆଇଆଇଟି ଖଡଗପୁରର ପ୍ରଫେସର ଥିଲେ। ସେ 93ରେ ଏକ୍ସପାୟାର କଲେ। तांको मिसेस को मध्य प्राय 86 ହେଇଥିଲା से पीएचडी कले तो पचारि आपण एते वर्ष रे पीएचडी करिवार कारण कोन से लर्निंग प्रोसेस होची गोटे एमती तार गोटे एज नाही तार गोटे कोनोसी बैरिकेड कोनोसी जगह नाही आपण जेते शिखिबे आपण सेते अलगा को शिखे को चेष्टा करंतु ताहले आपण जो सार माने आज आछन डॉक्टर साहा और तांका फ्रेंड्स जेते सब डॉक्टर्स अछंती आमे जहा को फेलिसेट करी कि ड्रीम्स बहुत भाग्यवान बेली कि आमे मन करूचु सेमान को मु ये करूची जे से माने केते हम्बल पिला माने तम माने आगुरु जानिबा दरकार जे तमे जेतेबेले सेही लेवल को हबा को चेष्टा करिवो ताले तुमको सेही भलिया डेडिकेट हबा को दरकार कारण सार चारिटा वार्ड कहचंती लास्ट रे जोटा कहचंती सेटा तम पिला माने प्राय ओडिया पिला माने समस्ते सुनिथिबो एठी जो बसचंती जगन्नाथ बसचंती तांकोठो बड़ डॉक्टर्स केही नाहंती से होचंती सबुठारु बड़ डॉक्टर तेनु आमे समस्ते चेष्टा करिबा जे ये कार्यक्रम जो आज टेक्नोलॉजी रो कार्यक्रम अछि ताको केमती बेस्ट एबिलिटी रे करिबा आउ समस्तक पई आमे जने डॉक्टर्स को जेतेबेल तार रोग भल हो जाउची से भाबुची मु डॉक्टर ता हला भगवान मु से डॉक्टर माने गोटे बुढ़ी लोक अच्छी से आसिक मुंडिया मारुची ताको गोटे यंग पिला पाखरे तार रीजन हला से भाबुची ये मो पई भगवान तेणु मु आज खाली पिला मन को गोटे जिनस कहबी कारण तमे एठुरु शिखिबो तमे एटा इम्प्लीमेंटेशन करिवो खाली आमे शिखी गले किछि हबनी आमे ताकू इम्प्लीमेंट करिकिरी केमिति ग्रामांचल रे सेटा को ठीक भाव रे करिबा सेटा को आगे देखिबा दरकार कारण आम कॉलेज ग्रामांचल रे अछि कारण गाँ रे लोक केमती भाव रहउचंती कोन करूचंती तम माने भलो भाव रे जानिचो तेणु एटा को इम्प्लीमेंट ताकू भलो भाव रे जदी करिबा ताले आमे जो आज वर्कशॉप करिचु तार निश्चित भाव रे सदुपयोग हेला बेली की मु भाबीबी धन्यवाद
Thank you so much, sir. Every event, no matter how well planned, reaches its true potential only with the collective contribution of individuals working behind the scene and those who guide us from the front. To express our gratitude to all those who made this workshop possible, from our respected dignitaries and guest speaker to the organizing team, faculty, and dear participant, we now call upon a dynamic and respected figure, Dr. Shakti Prasad Das, sir, member of Board of Director, Dreams University, to formally propose the vote of thanks. Please, sir.
Thank you. I don't want to waste time. Respected dignitary of the dais. First, I want प्रथमे मु धन्यवाद देबी Dr. Maulin, Shah, Nischal, and Tejas. Se mane first they agreed to come here to spend their time. I know they are very busy. Since 6 months, this program has been fixed, and they agreed to come here and to have to educate us. So, Satibenga Maulin, I will thank you all. Then I will thank the Dr. Pramod Chandrat, who has given all the facilities here. He had facilitated. You do whatever you like. All establishments are there. You utilize in which way you are possible. He has given us the free hand to do all these things. Then that's why I also thank him and also his all administration. Everybody is involved in this. I thank Dr. Kaniram Mahapatra Sir, President, Odisha Orthopedic Association, Indian Orthopedic Association, those who have given permission to use their logo and to conduct this program on their banner. Dr. R.N. Mahanti Sir, Pediatric Orthopedic Society of Odisha, he is also the guiding spirit. I thank Dr. P.K. Sahu, Anil, those who have also come forward to help us in many ways. And again, my colleagues Durga, Jyoti, School of Physiotherapy, Occupational, all the faculties, they have tirelessly worked to make it a success. And again, I thank all of the students, those who have joined here. Our aim is basically already discussed many ways. Even if one patient comes with that, he should not be neglected. You should identify them and you should treat, if possible, you treat them. Otherwise, you treat or refer to the proper person. It should not be neglected that I don't know this treatment is available there. That is our aim. So hope all will be benefited. With these words, I conclude my speech. Thank you very much.
Thank you so much, sir. With that, we conclude the inaugural ceremony of this workshop. As we prepare to move forward with the sessions ahead, let us take a moment to honor our nation. So, I kindly request everyone to please rise up for the national anthem.
ମୁଁ ସରି ମୁଁ ଭୁଲିଗଲି ମୁଁ ମିଡିଆ ବନ୍ଧୁ ମାନଙ୍କୁ ମଧ୍ୟ ଧନ୍ୟବାଦ ଜଣାଉଛି ଆପଣ ମାନେ ଆମ ନିମନ୍ତ୍ରଣରେ ଆସି ପହଞ୍ଚନ୍ତି ଥ୍ୟାଙ୍କ ୟୁ ଭେରି ମଚ୍ ଜଲ୍ଦି ହେଇଗଲା ଟିକେ ଓକେ ରାଜିବ ନା Ready? So I request all to join the lunch, all the faculty, chairman sir, and all the media friends, please join us with the lunch. And the inauguration program conclude here. Within 30 minutes, we will complete the lunch. Then we will congregate here for the further discussion. Thank you very much.
ଇଏ ଗୋଟେ ଲୋକ ମାନେ ତାଙ୍କର ମାନେ ଗୋଟେ ଏଣ୍ଡଲେସ୍ ଥାଏ କିଛି ଇଏ କରି
In external rotation, but you will lose abduction in turn. So you must understand this conglomeration of biomechanics. And Dr. Howard Clark, who was the pioneer of brachial plexus reconstruction, who devised the cookie test, they recently came up that surgery for internal rotation contracture in infancy should be done prior to the nerve surgery, and in many cases it may obviate the need for brachial plexus reconstruction. When internal rotation contracture is significant, the child would not be able to perform cookie test because his arm is in such a position that child cannot reach to the mouth. And so the principle is you address the internal rotation contracture initially and then see whether this child is a candidate for nerve surgery. And nowadays in many instances we do both the things together, like we do the reduction of the joint and simultaneously we do the nerve procedure, and this patients undergo shoulder spica. So I will talk about shoulder rebalancing in two cohorts. One is in infants and other is older children through some case examples. So this is the first case, a 6 months old boy diagnosed with Naracas 1. And you now know what is Naracas 1. It's a purely C5-6. There was recent reduction in the range of passive external rotation. And the therapist reported that earlier it was 80 degrees and now it is 50 degrees. So the question is, what is the right way of measuring passive external rotation? And what degree of passive external rotation is worrisome? In older children, we can make them sit upright and see what angle it makes the forearm to the trunk. And you must be stabilizing the scapula. If you are not aware how to assess the amount of external rotation, then your finding will be entirely different than mine. and the treatment depends on the degree of rotation. So you have to be very precise. The best way to assess external rotation in younger children is to check under supine position. And by doing this, you are compensating, you are not allowing any compensation from scapula. And we know that any passive external rotation less than 60 degrees alarming. You must be watchful for shoulder subluxation. And we publish our series and this paper in JPO 2022. And we found that if the passive external rotation goes less than 40 degrees, and if there is presence of a deep anterior crease, all those patients had ultrasound diagnosed hip shoulder dislocation. So remember two things. If a child is having passive external rotation less than 40 degrees and there is a deep anterior crease, this is 100%. All the patients on our study had posterior subluxation on ultrasound. On ultrasound, you do an axial scan, and this is the humeral head. This is the dorsal border of scapula. And this angle, if it is more than 30 degrees, and the capital humeral epiphysis is behind the dorsal scapular line, this defines the posterior shoulder dislocation. So the patients where there is beginning of internal rotation contracture, you must intensify the therapy, task-oriented active movements, hold and relax techniques, stretch in suboptimal range. The Tejas will talk about it in the next session. And we need to splint them at the night time. What you say is a teapot splint or external rotation splint or aeroplane splint. In very young children, we also apply what is known as super splint, that is supination and external rotation splint, a splint with a corset, and there are straps which ties from behind and keeps the arm supinated and externally rotated. This is done in very young children where they are not amenable to the bracing. Coming to case number 2, now this is a little higher age, 8 months old girl with a recent reduction of passive external rotation from 60 to 20 degrees. The parents complains the child is having persistent internal rotation posture and there is limited abduction and external rotation. And so unfortunate. Oh, it started working. So you see this child, look at very carefully the arm position in the space. The arm is persistently in internal rotation. There is good degrees of abduction. Abduction is about 100 degrees. But there is a deep anterior crease there. The arm segment is short and the alpha angle is 60 degree. There is posterior subluxation. We take this patient under anesthesia, do passive reduction, close reduction. We do ultrasound to make sure that the humeral head is well located in the joint. And once it is done, we inject subscapularis and pectoralis major with Botox injection and apply a shoulder spica in this position for about 3 weeks. And 1.5 years follow-up of this child. And you can see the amount of abduction and external rotation this child has. And this child did not require any further surgery. So how Botox works here? Botox temporarily relaxes the tight internal rotators and it allows the external rotators and abductors to recruit, and its action lasts beyond its stipulated time, and it allows the neuronal representation of this abduction and external rotators. So in the process of their recovering abductors and external rotators, these patients will improve and they won't need any further surgery. This is a technique and it's described in our paper how you give it. If I share our results of 95 patients of botulinum injection for infantile dislocation, we followed 62 patients with more than 3-year follow-up. What we found that 44% patients did not require any surgery, 44% required subsequent shoulder rebalancing, and 12% patients developed external rotation contracture. So which patients did not require surgery? Those who have very good HSC-AMS abduction elbow flexion. So their C5-6 root recruited muscles were all already recruited, but because of tight internal rotators, the external rotators was not giving action, and you temporarily relax internal rotators and now they are starting movement. So if you have very good HSCAMS of abduction and elbow flexion, these are the golden responders with Botox. Those patients who have low abduction and elbow flexion, they required surgery, suggesting that their C5-6 root were incompletely recruited. And those patients who have weak triceps and wrist dorsiflexions, meaning that they have C7 involvement, they develop external rotation contracture because subscapularis is supplied by C5, 6, and 7, and you are relaxing or weakening already weakened muscle, and those patients will end up into external rotation contracture. So our current practice is not to inject into patients where the external rotators are not the C7 muscles are involved. We just do close reduction. We don't inject Botox. For older children where the muscles are very tight, passive external rotation is less than neutral, we have devised a technique, minimally invasive subscapularis release, and its results. And this is a technique. There are different ways of releasing internal rotators, including arthroscopic release or anterior open release or open slide from the lateral border of scapula. The problem with all this technique is there is a high potential that you are making the internal rotators weak. Releasing subscapularis and the capsule at the insertion invites the anterior instability. And this technique, which I'm showing you in a moment, it finishes in 5 minutes. Patient is given lateral position. The arm is abducted, internal rotated so that the medial border of scapula becomes prominent. A centimeter incision is placed at the junction of upper 1/3 and lower 2/3 of scapula. Arteries pass through the rhomboids, and a 0.6 millimeter periosteal elevator is now introduced. And then gradually, in a clockwise fashion, you are releasing the subscapularis from the undersurface of scapula. The septas at the 1 o'clock and 5 o'clock position right here, and at 5 o'clock position where the teres major inserts on the lateral border of scapula are tight, and you introduce about 8 millimeter periosteal elevator, and a gentle stretching over 5 minutes is done, and the passive external rotation improved from 0 to 90 degrees. And in one sit the procedure is over, and then you can proceed further for your tendon transfer if you want to do. So by the time the arthroscopic setup is done, our procedure is over. And we have studied 5-year follow-up of our patient, and our results are comparable with the conventional open procedures. And so at many places in the world, people are now following this technique. So if I summarize the infants with interrotation contracture, the treatment depends on the range of passive external rotation. If it is 60 to 45, it is termed as a beginning of contracture. Between 44 and 10 degrees, we term is an established contracture, and less than 10 is neglected contracture. For beginning of contracture, you have to intensify the therapy and provide splinting. For established contracture with C7 element, you do, if C7 element is absent, there's pure C5-6, then you do Botox and casting. But if there is extended palsy, then you just do close reduction and spica. Don't do Botox because they can develop external rotation contracture. For neglected contractures, you might require internal rotator release, which can be minimally invasive way, open or arthroscopic, with or without tendon transfer and with or without nerve transfers. Different centers do different practices, but you have to apply shoulder spica. So this was about how you manage the infants. Okay. Coming to older children, this 3-year-old boy presented with limited shoulder elevation and arm internal rotation posture. Look at this boy and his video. So you see his arm is persistently internally rotated, elbow is pointing laterally, and it is very difficult for him to hold any object. He needs support of other hand to reach to mouth, the way he holds the ball, you see. And if you give anything to hold, his position is so, he has significant trumpeting, and the child has very limited in his function. Now, management of these children, older children with glenohumeral dysplasia, the management depends on congruency of glenohumeral joint on MRI. And Dr. Peter Waters is the one who devised this classification. On axial MRI, we see the degrees of retroversion of glenoid and the percentage of humeral head subluxated. So there is a gradual increase in the dysplasia. The first stage is just retroversion, and then if it lasts further, it will go with subluxation, retroversion with subluxation. But both this variety still has congruent glenohumeral joint, and so that you can do soft tissue rebalancing, meaning that you do interrotator release and tendon transfer. But if the deformity goes further, like it becomes a false glenoid or completely dislocated glenohumeral joint, then it becomes non-congruent glenohumeral joint, and there the soft tissue rebalancing would not work. And we would like to do bony procedure like scapular neck osteotomy or humeral derotation osteotomy. Coming back to our child, the boy which I have shown you, he has type 4 glenohumeral joint, non-congruous. This is a normal glenohumeral joint, but we performed minimally invasive subscap release and axillary approach conjoint tendon transfer. And this is the outcome of that child. His abduction improved substantially. His external rotation improved well, and trumpeting also resolved. See, there is the active external rotation. Moreover, if you see the follow-up MRI at 1 year, you can see the glenohumeral joint got completely remodeled. And this happens when you do soft tissue rebalancing in younger children, less than 5 years, they remodel after glenohumeral correction. So glenohumeral remodeling can be expected after soft tissue rebalancing in children less than 5 years. Let's see older children. This is 12 years old boy, and he has significant trumpeting. He has significant interrotation posture, but his glenohumeral joint surprisingly is not non-congruent. It is retroversion and subluxation. And so we performed same minimally invasive subscap release and tendon transfer, and that gave improvement in the posture as well as the trumpeting resolve, meaning that soft tissue rebalancing can be done at any age provided glenohumeral joint is congruent. And I have done one in 18 years old boy. So age will not decide whether you need osteotomy or soft tissue rebalancing. It's the congruency of glenohumeral head which will decide. Now again, look at this 12 years old with 180-degree trumpeting. So this is the highest trumpeting I have treated ever. In order to reach mouth, this child needs to lift the arm at 180 degrees. And again, we performed the similar procedure, and we could resolve his trumpeting, and child's function improved. He has an extended or global palsy, so we would require something for wrist, but he was so happy and they didn't turn up. So soft tissue rebalancing can be done for any degrees of trumpeting, okay, provided glenohumeral joint is congruent. Coming to bit older child, again the same phenotype of presentation, but child is 9 years old and there is type 4 glenohumeral joint. In these cases, we do glenoid anteversion osteotomy to make the joint which is non-congruent to a congruent joint where our tendon transfer would work. And we published this in JBJS way back when I was in sick kids, wherein we do glenoid anteversion from posterior approach and put a bone graft. And this is our publication. And this leads to improved function as well, you can see. And the remodeling again happens in these children. The glenohumeral joint gets congruent after glenoid anteversion osteotomy. So we perform this osteotomy in children between 5 and 10 years. Less than 5 years, you just do soft tissue rebalancing. But what about adolescents? So this is an adolescent girl, and there is clinically palpable subluxation, marked trumpeting. Here we do derotation osteotomy, and the results are very promising. We have to do this surgery in older children because they have very poor remodeling potential. But if I perform this in 5-year-old, then this shoulder joint will remain subluxated for the lifetime. So this is termed as primary derotation osteotomy, where they present to us very late with a non-congruent glenohumeral joint. But what for some other children? Again, this young girl where I've done MISR and TT, and her abduction, external rotation improved substantially. She could reach behind the back. but still family is not happy because her arm is in persistently internally rotated posture. So this pointing of elbow was cosmetically worrying the family, even though she has reached all the functional gain. And then patients used to ask me, you promised that she will do well, but why this cosmetic hindrance is there? And then we studied these patients by doing concomitant imaging. We overlap the axial shoulder and elbow images, and we found that these patients have significant rotation in the humerus. And so these patients would need a secondary osteotomy to correct this rotation. So we did perform derotation osteotomy in this patient to improve their cosmetic appearance from here to here and from here to here. And this is what we term as secondary derotation osteotomy. So if I summarize, child with internal rotation contracture, older children, we do axial MRI and find whether it is congruous or non-congruous. If it is congruous, at any age, you do interrotator release and tendon transfer. But if it is non-congruous, then we find out what is the age range. If it is less than 5 years, you can still do interrotator release and tendon transfer because it will remodel. More than 10 years, you do derotation osteotomy. But between 5 to 10 years, you do glenoid anteversion osteotomy and tendon transfer. So this is in nutshell our recipe for managing glenohumeral dysplasia or interrotation contracture in very young children. Those children who have persistent interrotation posture, I perform secondary humeral derotation osteotomy. So thank you very much. Any question? Mike, Vijay, Bhaiya. Hello.
Well, Dr. Shah, I think young people may not be able to understand what he has told because they're very complicated assessment and also the results are very much alluring you must have seen before stop. My question you to is,
Yeah.
in these young children doing an osteotomy, and do you have any problem in the growth of the particular limb?
No, growth is not a problem, but if they are very young and you perform a derotation osteotomy, every time they do midline function, posteriorly subluxed humeral head will go further posteriorly, right? And then you are not addressing the primary element, that is internal rotation contracture. So you are not doing soft tissue release. So there is a paper from Sweden where this derotation osteotomy remodel over a period of time, and they need to do a secondary procedure. And there are certain patients who develop arthritic changes because of long-standing posterior dislocation. And so we try to normalize the joint as far as possible. But after 10 years, what I found is that the cartilage is very thin. And if you try to put it back, then there is a chance they may turn stiff. They need a good rehab. And these children who have neglected this problem for more than 10 years, they will not cope up with rehab as well. So after 10 years, I performed derotation osteotomy.
So what about the bone density of these patients and about doing a arthrodesis on the joints, as you mostly do in cases of adult brachial plexus? So do you do arthrodesis in these cases?
So
your experience and
arthrodesis would be needed if there is none of the rotator cuff and deltoid, they are functional. So in those cases, you want to put the arm in a bit of functional position. But all these patients, who come to us fairly early, then we do not let this, if they are flail, then we operate. So we do nerve surgeries and then we get some rotator cuff power. And those who come little late, we have some tendon transfer to restore, like lower trapezius to deltoid and external rotators. So we have not yet come to a stage that we require this shoulder fusion. Some of them I have prescribed a completely flail limb, but they have not turned up. So I have done only one.
did you do a trapezius transfer of the insertion?
Yeah. So we have done this Sahas transfer, but for Sahas transfer to work, the shoulder needs to be stable,
Yeah.
both anteriorly and posteriorly. So if you have rotator cuff weakness, Sahas would not work. And many a times, those patients who have undergone this spinal accessory to suprascapular nerve, their upper trapezius is not functional. There we do EMG of the lower trapezius and we transfer lower trapezius to deltoid or even triceps.
So you see the insertion of the trapezius muscle into the humeral upper part of the humeral.
Yeah, what we do is we take a lumbar fascia
Yeah.
and then take the trapezius, and at the angle of scapula there is a nerve. So we flip from there and make tunnels, and we transfer to humerus and the deltoid and triceps at times.
Okay, thank you very much. Any questions? So many people don't have questions, sir. You should.
Okay, so yeah, if there's no question, that this is the most common deformity, and being a therapist, you need to identify when the passive external rotation range reduces from 60-degree down. This patients may develop problem in future, and then you need a close supervision. And Botox is in infancy and soft tissue release tendon transfer in older children, it works well. Yes, Tejas. Now we are breaking. है ना, कहूँ से- के- नहीं हुआ तो तारा therapy ना. Before splitting up, it's पता ही नहीं है ना, module. Okay, so now I think we should split. For there was a small talk by Tejas about a therapy protocol for us to see, because then we will not see. I think we should attend that lecture and then we'll split. Tejas, so if you can
नहीं अभी नहीं, थोड़ी देर के बाद, इसके बाद 5-10 मिनट के बाद.
हो जाएगा अपन लोग.
चलेगा मुझे इधर, मुझे नहीं चाहिए, ये आ नहीं रहा है. हाँ.
So, so before we split, we we have a small talk about how, as a therapist, we approach a child who are having the brachial plexus injury, and how we should approach who underwent for the shoulder rebalancing and the plastic neural reconstruction. So the comprehensive rehab approach of brachial plexus birth palsy typically divides into rehabilitation of infants and rehabilitation of young kids. So these are the few approaches like TMR, aquatherapy, electrical stimulation, close kinematic chain exercise, task-oriented exercise, constraint-induced movement therapy, kinesiotaping, and the use of the splints and the orthosis. We use these approaches for the rehabilitation. Now, let us go one by one very quickly. The first things we do is a TMR, that is total motion release. It's very innovative osteopathic technique. It helps to relieve the restrictions, helps to restore the symmetry in the body, helps to develop the postural control, and finally to augment the function. How? By moving into ease, by deep shortening the tight tissue. You heard correctly, instead of stretching, we do the deep shortening of the tight tissues. Now, let us go to the case study. the child who is having brachial plexus birth palsy on the right side, and soon after removing the spica, he had the shoulder rebalancing surgery. This was the range of motion on his shoulder on the right side. And what we did, we actually practiced the easy movement. The easy movement was he's having the right side bend better than the left side bend. His right lower twist was the better than the left lower twist. His left upper twist was the better than the right upper twist. And of course, along with all this movement, I combine the left arm abduction. And we deep shorten the tight tissue. And you can see after the 1 hour of the session, this was the range of motion we could achieve after doing the TMR. So TMR makes your better platform to build up the further course of the treatment. The next thing is aquatherapy. The aquatherapy with the help using the different dynamic hydrodynamic principles of the aqua, water, buoyancy, viscosity, hydrostatic pressure, turbulence, and metacentric effect, and its own thermal conductivity of the water, we can make therapy very easy and very engaging. Video, yeah. Yes. So here I'm trying to, strengthen the child inside the water with the use of the different hydrodynamic principles of the water. And why water? Because of the buoyancy. When we do the exercise on the floor, we have a gravity, But when any human body which is immersed inside the water, that feels the different force, that is a buoyancy, that will have a different another property of the water, that is a viscosity, hydrostatic pressure. So movements becomes more easy, movements learning will be more easy, and it will be a painless faster recovery inside the water compared to the land. So these are the few examples of doing the exercise in the water. So along with the increasing the strength of the muscles, we can also increasing the stability at the proximal joint with the help of aquatherapy. So I will talk in detail in the next talk. Another thing is electrical stimulation. So this is my selection. This is how I select the electrical stimulation, the type of current on the basis of HSCMS. You can see from grade 0 to 4, I would use interrupted galvanic current. For 4, 5, 6, 7, I can try the surge Faradic current, and then for better function, functional electrical stimulation. So this is a very sophisticated, very handy functional electrical stimulation we have. It is Chattanooga continuum, and this switch makes difference. Now let us understand how it works. The child who is having the overhead activity, abduction and extension at the elbow, and you can see there is a lag in the extension of the elbow. He's not able to do the full abduction and extension at the elbow. What we did, we kept the FES at the triceps, deltoid, and the adductors of the scapula. So along with the movement, we are trying the electrical stimulation, and that last range of the leg will, fulfill by the functional electrical stimulation. And this will help to make the better perception of the movement inside the brain. And this is how we can, increase the range of motion in the end range of the motion. Close kinematic chain exercise. Everybody are, well aware about why we need to do the exercise in the weight bearing exercise, in the weight bearing position. So for the better stability, you need to do the isometric co-contractions at the proximal joint, adductors of scapula, deltoid, co-contractions of the deltoid, triceps, biceps. So if you will get the better stability at the proximal joint, you will be having the better mobility at the, distal joints. So this is the idea behind giving the exercise in the closed kinematic chain exercise. Constraint induced movement therapy. Of course, we have to block, we have to restrict the movement, we have to use the use of unaffected side. There are the different ways of doing the constraint. So it is very necessary to constrain, and you have to introduce the constraint from the beginning when they start sitting. I will talk in detail in the next session how to constrain and what is the indication and what are the benefits of doing constraint in the early age. Kinesiotapping. So kinesiotapping for the facilitation, kinesiotapping for the stability, kinesiotapping for the inhibition of the muscles. We use the kinesiotapping. So this is the kinesiotapping for the scapula stability, deltoid inhibition of pectoralis major, triceps facilitation, wrist extension, external rotation, and the supination. So we use a kinesiotapping intensively, especially we use the kinesiotapping in the especially weekend, or they are going for the long off holidays. So we do the kinesiotapping for the kids. Task oriented exercise. You select the movement, you select the play in a such a way that you want to target those muscles. So create a play in a such a way that child is actively involved. Okay, you on the basis of uh, your plan, and create a play in a such a way that child is actively involved, and that is what we want in our routine function. So target oriented exercise at the end of the therapy session is also very necessary. So these are the few examples of target oriented exercise. Now, if I'll talk about the rehabilitation of infants, of course, I will start with the TMR. TMR is, tool which helps to release, organize, and activate the affected muscles. And of course, it is a painless tool. After doing TMR, we'll do the tactile exploration, hand to hand, hand to mouth, hand to torso, just to, initiate the neuroplasticity in their child's affected brain, because they will start learn non-use. Joint compression for the better proprioception and increase the awareness of the affected limb. And then gentle passive range of the motion within the pain-free range. Don't go beyond the pain range. Gentle passive range. Then electrical stimulation. And then, create a play in the supine and in the prone. And these are the few examples of splints which we use in the brachial plexus injury. Aeroplane splint, pedirep, functional elbow dynamic splints, push elbow, night splints, cock up, and the dynamic cock up. So these are the few examples. Thank you. Thank you very much. Now, we will go in the detail for each and every approach in the next session after, we split. Yes. So everybody, so as I just talked, the framework which we use for the rehabilitation of the brachial plexus injury at our clinic. So these are the, once again I'm just briefing this slide, I'm repeating this slide. So we start typically with the TMR, and then we use aquatherapy, and then we use electrical stimulation, closed kinematic chain exercise, and so on. The whole rehabilitation is divided into, the rehabilitation of infants, and then pattern of recovery, how the kids recover naturally or after the neural reconstructions or after the shoulder balancing surgery, and then rehabilitation of young children. So for the better understanding, let me start with the rehabilitation of young children, and then we'll shift to the infants. So first of all, I'll talk about the TMR. So as I said, TMR is very innovative approach, helps to relieve the restrictions, helps to restore the symmetry, and helps to develop the postural control, and finally to augment the functions. And how? By moving into ease, by deep shortening the tight tissues. Now, everybody will be having the, question that till now we are learning the stretching to release the restrictions. उस तरफ नहीं आ रहा है. Till now we were learning that we have to do the stretching to release the tightness and to relieve the restrictions. How all of a sudden you are saying the exact opposite of what we are learning? Yes, you are right. I'm saying deep shortening of the tight tissue. Don't stretch, deep shorten it. By moving into ease, by deep shortening. How? Now let us take a one example of the bow and arrow. If a bow and arrow, if I want to change the string of this bow, I have to bend that, bow, and then I will be able to release that string, and then I will be able to increase the length of that string, right? The same way, the children who are having the cerebral palsy, you must have seen that they are sitting on the sacrum. And why? Because of they have lot of restriction at their anterior side of the body. So what we are doing? We are directly elongating those muscles. So what TMR says, don't elongate. You go deep into it. You deep shorten it. आप उसको और ज़्यादा deep shorten करो, hold करके रखो. And then you will be having the better range. And then you do the active exercise for the extensors. Now, my mentor, my teacher, Beverly Cusick, told me that deep shortening gives a tissue a drink. What does it mean? Let us understand the science behind the deep shortening. How deep shortening helps to elongate the soft tissues. So, because of the continuous tight status of any soft tissues, there will be restrictions of the fluid inside the tissues. And because of that, tissue will be dehydrated. And why it happens? Because of the constant pressure on the microcirculars, micro vessels within the tissues. Now, if you'll deep shorten it, the pressure on that microvascular structure will be released, and it helps to rehydrate that soft tissues. And because of the rehydration of that tissue, the tissue will become more rehydrated, more malleable, and it will be more what do you say, in better position for the better elongation. So this is the science behind the deep shortening. Now in TMR, we work globally instead of focally. As I shown you, I'll show you the whole treatment protocol. And it basically more work on the modified counter strain, and we deep shorten the tight tissues around the affected part by moving the unaffected part. And why this happened? This happens because of the interconnections of the fascia from head to toes. Now, let us understand case studies in detail. So, this is the child which I have showed you, the child who is having the brachial plexus injury. He is having the restriction of the abduction soon after the removing of the spica. This was the abduction was possible after removing of the spica. This is the pre-test. Now, in examination, what we found. So, on the basis of TMR, we have examined him. And what we have found, child is sitting into this position. Right side flexion, right side upper twist, and left side upper twist. So he's sitting into this. Okay. So he has tightness in this side of the body. And you can see. Okay. And he's also having the better abduction on the opposite side, right? Now, very precisely, I'll told him that you do the side flexion of the both side. And you can see he's having the better right side flexion on the right side compared to the left side. Can you appreciate, everybody? He's having the better lower twist on the right side. You can see he's able to lift his right pelvis in a better way compared to the left side. See, this is the right side and this is the left side. He's having difficulty to lift his pelvis on the left side. Of course, he's having the better abduction at the shoulder on the left side compared to the right side. And his twist, upper twist on the left side is better than the right side. Now, what we found on our examination, we found the restrictions where right side band is, left side band is more restricted to the right compared to the right side, right lower twist and left upper twist. Okay. So opposite side of the movement is restricted because of this side is better. So what I did in my session, I literally deep shortened those tight tissues. I have not touched, I had not touched his right shoulder at all. And I deep shortened towards the easy side. I kept on doing the right side flexion, which was the better in his compared to the left side. I incorporated left side shoulder abduction along with the right side flexion. I deep shortened his right side lower twist. I deep shortened his left side upper twist. See, instead of touching the shoulder, TMR says work globally. You try to relieve the restrictions from the peripheral part of the affected area. And then what I did, in the end, I literally kept him into, I combined all the movements and I kept him into a shortest position, right side flexion, right lower twist, left upper twist, and the abduction of the opposite side. I kept him into a 2 minutes. And then I gave him some sensory input. And all of you have seen the post test. This is what I have done in my 45 minutes of the session. I have not touched his shoulder. Now, the take home message for the TMR is, it works on the counter straight. When you deep shorten the tight tissues, it helps to rehydrate. It helps to, increase the malleability of the tight tissues and helps to better elongation. TMR makes a better platform for the further course of the treatment. And this is the example for the cerebral palsy. You can see in the picture which is above, the child is having, malaligned position in the supine position. Everywhere he's having the restrictions. And after doing the TMR, he's so relaxed. And look, you can appreciate in his facial expression also. The next things I'm going to talk about the aquatherapy. Now the question is why we want to choose the water as a media for the therapy. Water is why? Because of water is absolute fun. It is a wonderful media. No, we choose water because of its own hydrodynamic principles and the therapeutic effect of the water. Now, what are the hydrodynamic principles? Buoyancy, viscosity, hydrostatic pressure, turbulence, metacentric effect. These are the hydrodynamic principles of the aquatherapy. Now, let us understand one by one how these hydrodynamic principles helps therapy very easily helps in a rehabilitation. So first of all, we'll take the buoyancy. Now, in simple terms, buoyancy is something to afloat. When any human body or any object which is immersed inside the water, which feels the upward thrust, and that is the buoyancy, right? Now, what are the therapeutic benefits of higher buoyancy? So, because of the buoyancy, you will feel very light inside the water. That makes movements very easy, and it will be easy to facilitate any kind of movement inside the water. And it increases the participation, active participation of the child inside the water. The another hydrodynamic principles is the viscosity. And in simple terms, is the resistance to flow. Now, the combination of the low viscosity and the resistance you cannot find in any other media other than the water. Now, what are the therapeutic benefits of the water, viscosity? The viscosity will give the resistance and it helps to strengthening. It helps to strengthen the joints without straining the strengthen the muscles without straining the joint. And compared to the land, the reaction time, falling reaction time is much more in the water. And that's why, you can give the fall prevention training inside the water because of the viscosity. Can anybody tell me about the hydrostatic pressure? What is the hydrostatic pressure? You must have studied in the physics. Can anybody, in simple terms, what is hydrostatic pressure? Okay, so when we immerse inside the water, you will feel the pressure. Okay, and it will act like a shoot, or you will feel like a hug, inside the water, and that is the hydrostatic pressure. So because of the hydrostatic pressure, it increased the flowness, it increased the precision of the movement. And because of the hydrostatic pressure gives the constant sensory input during moving inside the water. When you move inside the water, water will give you the hydrostatic pressure, and that gives the constant deep pressure effect, and the motor learning is much better because of the hydrostatic pressure. Because of the hydrostatic pressure, you will feel less pain. Soon after the single event multi-level surgery or soon after any surgical procedure, you will do the aquatherapy. Because of the hydrostatic pressure, the perception of pain is much lesser inside the water. The next hydrodynamic principles is the turbulence. In simple terms, it drag. So when we work against the turbulence, it helps to strengthen our joints, muscles, and when we work towards the turbulence, it helps to mobilize the soft tissues and the joints. Metacentric effect. Now, when we immerse inside the water, we feel two kind of force on our body. One force which is from the bottom to up, that is buoyancy, right? and another force from top to bottom, that is the gravity. Now, when these two forces are aligned with each other, at that time we have a stability inside the water. But we can disalign these two forces to create the torque inside the water, to create the rotation inside the water. And that is called the metacentric effect. You know, when we counteract the metacentric effect, we have to, do the muscle work, and we have to work at our core to stabilize our body. And it helps to, give the strengthening. And when we allow that torque, when we allow that rotation, it helps to mobilize the soft tissues. Thermal conductivity of the water. The thermal conductivity of the water is 25 times faster than the air. When we work inside the water, it whisks away the excess heat of our body, and it creates a cool environment of the body. So when we are working on the land, heart has to pump a lot to keep our body cool. Now, when we immerse inside the water, so heart is not busy in pumping the blood to keep our body cool. Heart will be supplying the oxygenated blood to the working muscles. And because of that, you will be able to work a prolonged period of time inside the water, you know, because of the heart constantly pumping oxygenated blood to the muscles. It helps to remove the waste products very efficiently. And because of the thermal conductivity of the water, you can work out more vigorously for prolonged period of time compared to the land. So these are the advantage of the different hydrodynamic principles and the thermal conductivity of the water. Now let us go. What are the strategies we use in the aquatherapy? And these are the few strategies we use to rehabilitate or to strengthen the muscles for the children who are affected with the brachial plexus injury. Have a look. Here I am strengthening the deltoid in supine position. External rotations while using the float. Using the viscosity as a hydrodynamic principles, I am strengthening furthermore. I am strengthening the external rotation furthermore. Now it is very difficult to strengthen the adductors of scapula on the land, but water makes it very easy, while using the buoyancy as a hydrodynamic principles. Here the buoyancy is assisting. Again, using the viscosity to strengthen furthermore adductors of scapula. Forward flexion and extension. Strengthening of triceps and mobilizing of the, shoulder and the scapulothoracic joint. facilitation of biceps using the flotation nets. Now, against viscosity. So when you do the slow motion inside the water, it will facilitate that movement. But when you do the fast movement inside the water, it will resist. And that is, the advantage. And that is how we can play, to increase the strength. Now, these are the few more examples, by moving the distal body and fixing the upper limb with the one fixed point of contact. Now, why we want to do this? Because as I said, for the better stability, you have to, for better mobility, for better function, you need to have the better stability at the scapulothoracic joint and the deltoid and the shoulder joint. So these are the few strategies, which helps to give the lot of isometric co-contractions around the scapula as well as the deltoid as well as the shoulder joint and helps to increase the stability at the scapulothoracic joint and the shoulder joint. So this is our therapeutic pool at my clinic, and it is an indoor temperature control pool. So therapist is now working in the supine position and they are working into adductors of the scapula. And this strategy will also help to increase the expansion of the pectoralis group of muscles. So along with the increasing the strength of the scapulothoracic joint and the shoulder joint, it also helps to increase the core. Now the next is functional electrical stimulation. Now everybody knows that why we use the electrical stimulation. Okay, so to prevent the diffuse atrophy, to helps to escalate the nerve regeneration, for better muscle re-education, helps to relieve the pain, especially neuralgia, and helps to reduce the edema. Now, as I said, this is this is how I select the type of current. Till 4, I typically use interrupted galvanic current. For 3, 4, and 5, I use surge Faraday current. And for 5 onwards, along with the surge Faraday current, I may use functional electrical stimulation. As I shown you in earlier that we are using this machine at our clinic. This is the functional electrical stimulation. Now let us go one by one. The case studies, how we use. The child is doing the wrist extension without a functional electrical stimulation. And now this is the wrist extension movement with functional electrical stimulation. Okay. And the therapist is having the switch while doing the movement. She is pressing the switch. That helps to recruit the more number of the muscles fiber and helps for the better motor learning. And this is the placement of electrode for wrist extension. Elbow flexion. Yes. हाँ जी, देख लीजिए. Two electrodes at the extensor group of muscles that goes to the one channel, and two electrodes in another channel, one electrodes at the thenar and another electrodes at the hypothenar. Clear? This is for wrist flexion. one channel at common flexor origin of the common flexors group, and another channel at the distal part of the common flexor group. Sorry, flexor group, not extensor group. External rotations. External rotation in adduction. And this is the electrode placement at the infraspinatus. Shoulder abduction and extension. One electrode at, so we will use two channel, one electrode at the adductors of scapula, one electrode at deltoid, and two electrodes at triceps. Supination, pronation. For the supination, we use single channel at the supinators of forearm and at the pronators of forearm. Now, this is the machine which I was talking to Dr. Arun sir. This is the restorative therapy. It is more sophisticated machine. As the machine which I have shown you, it has 4 electrode, 2 channel. This machine is having 6 channel, 12 electrodes, and very sophisticated and program oriented machine. Here I am showing the one function that is doing the abduction and putting the flexion and extension of the wrist. This is the program I am in simple term I am trying to do the external rotation and extension of the elbow. And this is the electrode placement I have kept. Biceps, long flexors, extensors of wrist, deltoid, triceps, and the external rotators of the shoulder as well as the adductors of the shoulder. And this is the function we are trying to do with the child. So this is the restorative therapy. ये कर रहा है बेटा, यहाँ से यहाँ जा रहा है. So for this also हमें flexion चाहिए, और ये खत्म करने के लिए हमें opposite group of muscles चाहिए. Yes, particular muscles particular timings पे stimulate होते हैं. Yes, पर इसमें biofeedback ग्राफ दिखाता नहीं है. So there are ready-made program inside the machine, और हमें manually settle करना है तो वो भी option है इसके साथ. Now close kinematic chain exercise. Everybody are aware about why close kinematic chain exercise for better proprioception. It activates the agonist, antagonist both the way. It helps to increase the stability, static as well as the dynamic. For the better eccentric and isometric co-contractions, improve the bone density. Now, everybody is aware that shoulder is a ball and socket joint, and it is most dynamic joint. And in the cases of the brachial plexus, the shoulder is mostly affected. So we have to increase the stability at the shoulder joint, and for the better function at the elbow and wrist joint. Okay, so that's why we do the close kinematic chain exercise. So these are the few examples of close kinematic chain exercise, weight bearing exercise for the brachial plexus birth palsy. wall plank. So in simpler term, you have to create a play in a such a way that child is actively engaged in your therapy session. And you can choose the dynamic surface, if you want, you can start choosing the bolster and then you shift to the ball, because bolster is a less dynamic surface than the ball. So depend upon the control, depend upon your need, you can choose the dynamic surface for therapy. Here I'm trying to strengthen the adductors, close kinematically. Now constraint induced movement therapy. Now it is a behavior approach based on the learn non-use. You have to restrain the less affected arm, and you have to introduce the repetitive structural playful activity, and you have to give the functional task. Now in my practice, typically I start doing the constraining at the age of 3 to 6 months to prevent the learn non-use, as I explained you. So typically start the constraining, before they start sitting. Why? Because if we fail to do the constraint and then once they start walking, it is difficult for them to comply in our therapy session. So these are the different way of doing the constraining. We can use the towel or a cloth to do the constraint. We can use the crab bandage or a paddy wrap. So initially life, at the age of 1 month, 2 month, 3 months, you can do the manual constraining, and then you can start using this prop for the constraining. Typically you do the constraining for the half an hour, and then during that half an hour you actively engage child into a play, and then after removing the constraint you do the bimanual activities, also equally important. No, performing the bimanual activity, it is equally important after removing the constraint. So sometimes we learn from the parents. The parents, just day before yesterday, parents have come with this idea. They made the jacket and for the doing constraining. And you can see there is a pouch which is inside. Child can move around with that jacket. And this can be done for especially the children who are having the less compliance. This is another method of doing the constraining. Now, you can do the intra limb constraint for the better function at the proximal joint. You can see the child is doing the shoulder abduction without constraining the elbow, and shoulder abduction with constraining the elbow. So for the better movement at the proximal joint, I would like to constrain the elbow joint. The child is having trumpet sign while doing the hand to mouth. If I want to make them learn the external rotation without having the abduction, I would constrain their humerus. Hand to mouth activity without creating the trumpet sign, I would like to constrain their humerus. Well, these are the few exercises for constraining. Kinesiotapping. Now, how kinesiotapping works? So, when we apply the kinesiotap, it gives a sustained stretch on the skin. It helps to activate the mechanoreceptors, and that creates the mechanotransduction effect, and that converts into an electrical impulse, and that helps to activate or inhibit the underlying muscles. Okay. Another effect, mechanical mechanism of kinesiotapping is when we apply the kinesiotap. After applying the kinesiotap, it will help to lift the tension and unload the pressure which is coming on the capillaries and the lymphatic tissues, and that is called the decompression. And because of that decompression, it helps to open up the micro valve and improve the circulation in within that soft tissues. And everybody else knows that when there is a circulation increase, the tissue will be rehydrated, and that rehydration helps to, that makes tissues more malleable and helps to reduce the edema and swelling. Now, in brachial plexus, we apply the kinesiotaping to activate the muscles. For the activation, you apply from origin to insertion. You apply the kinesiotaping in the shortened position, and to inhibit the muscles. To inhibit the muscles, we apply from insertion to origin. It helps, and it has to be applied in the elongated position. And you have to keep in your mind that during the base, while applying the base anchor, don't give any kind of a traction. And 10 to 15% of the stretch while applying on the belly. Now let us understand one by one how kinesiotap can be done on the different muscles. So this is for the deltoid. This is for the middle fiber and the lateral fiber combined. This is for the winging of the scapula. The one kinesiotap for the lower trapezius from bottom to up. Another for the adductors and the external rotation of the shoulder from medial to lateral. This is the another way of doing the kinesiotap for the scapula. This is for the external rotator, infraspinatus from middle to lateral for origin to insertion. Triceps from origin to insertion. Inhibition of the pectoralis group of muscles. Wrist extension. You can see with and without kinesiotap the amount of extension in wrist. Forearm supination. It is very useful in the hemiplegia and cerebral palsy also. Start from the lower end of the forearm. Keep your forearm into supination position. Give somewhere around 50% of the tension. Wrap it around the dorsum part of the forearm. Keep 20% at the dorsal side and at the lateral aspect of the forearm. Again, 50% at the volar side. And this is for the supination. Now, targeted strength training program. As I explained you, it is very necessary to keep child actively engaged into your play. Create your therapy session in such a way that child is actively engaged in your therapy session, and create a play in such a way that you are targeting the specific muscles. You are targeting the muscles which are weak. Okay, so these are the few examples of doing the strength training, task-oriented strength training program. That I'm trying to strengthen the elbow extension, shoulder abduction, all the overhead activities. all the fine motor activities, and majority of you are the occupational therapy and you are the better person, to keep child into a play, to keep child engaged into a play. So I'm trying to facilitate the internal rotation for this child. Child is having the difficulty in internal rotation, hand to tummy. So I'm creating play for that. Once I increase the internal rotation, it will be easy for child to do the midline activities. So do the constraint, do the electrical stimulation, weight bearing exercise, and last 15 minutes of your session should be, the task oriented activities, create a play, functional activity that helps for the better learning, better neuroplasticity. So once the child is done with the without doing the play activity, without having any weight, to increase the further strength, I will apply the sandbag at the wrist joint, and then I repeat all the play again. And this is how we can increase the strength in the muscles. Few stick exercise soon after doing the shoulder rebalancing surgery to mobilize the shoulder joint as well as the elbow joint, because they have kept into the shoulder spica for the 1 month, 1.5 months. So stick exercise, all of us are knowing very well. But the one things I am doing something different way, that I am constraining the different part of the body. I am not allowing any kind of the trick movement. I am tying up the child with the frame, and then I'll do the all stick exercise. Splints which are used in the brachial plexus. This is the aeroplane splint, paddy wrap. We can make the cock-up splint on the OPD basis, while using the cardboard and the micropore tapes and the bandages. The above elbow functional splint, for the children who are having the supination deformity. Push elbow splints for the night purpose, cock-up splints and dynamic cock-up splints. Thank you. Thank you very much. So let me know if you have any questions or, if you want to see one more case study is for the TMR, and I would like to, I'll show you one more case studies. Yeah, sorry. Uh, we have to talk about the rehabilitation of infants also. Now, how we approach the infants. So, when we encounter child at our clinic, first of all, we examine them, we assess them, we counsel the parents about the injury, we explain them mechanism of injury, and we explain about the prognosis. Okay, and our therapy program for the infants is typically divided into a first 2 months of their life and after 2 months of their life. So what we are doing, why we are giving the home program during the first 2 months of their life, because the infants are developing the immunity, mothers is recovering from lot of trauma, infant skin is very fragile because of the Valerian degeneration. you know you should not start the electrical stimulation during the first 2 months of life, and that's why we advise the home program. Now, as I said, we start with the TMR. We try to relieve the all the restrictions around the shoulder joint by initiating the TMR. Okay, and typically, as I shown you in the case study, typically the same thing. We are deep shortening the tight tissues. We are moving into a ease. And with the help of TMR, it helps to relieve, organize, and activate the all affected muscles. And then after doing TMR, we give the sensory input like this wiggle jiggle in supine position. It helps to reorganize all that tissues, and then we give them a tactile exploration, hand to feet, hand to mouth, hand to torso, and hand to forehead. After giving the tactile input, we do the gentle passive range of the motion within the pain-free range without stretching anything. And then joint compression for the better awareness. So these are the typical home program we advise to the mother. No, and we typically advise them that you have to repeat this home program exercise every before feed. So somewhere around 3 to 4 times in a day. And then after 2 months, at the 2 months of their age, once they come for the follow-up, we check them again, and it will be easy and it will be more precise after 2 months to classify them into a Narakas classification. Now, why we ask parents to come at the clinic after 2 months? Because we have to take the maximum advantage of neuroplasticity. And it will be better, always better, to have the child into a skillful hand. And that's why, and we have to start the electrical stimulation also. And that's why we call parents for the regular base of the therapy at the clinic, after 2 months of the brachial plexus injury. So along with doing all this stuff, which I have shown you before 2 months, we have to add the electrical stimulation. And on the basis of our finding, you can choose the type of current, interrupted galvanic or surge Faraday current. Again, you have to engage child actively, into a play. in supine position as well as in prone position. You have to encourage the weight bearing exercise. You can use the, what do you say, uh, baby gym and floor mat for the supine and prone position. And then if child is not improving at the age of 3 months, if you are not seeing any kind of, substantial flickering contractions at the biceps, and all the muscles are clearly involved, then it is a classical case of Narakas 3 and 4. Straight away, you have to go for the plastic neural reconstruction. And this is very necessary, all of you, to understand that pattern of recovery after the plastic neural reconstruction. So once the plastic neural reconstruction done, you may see some deterioration of the movement. The motor power which we have achieved during first 2 months of their life, you might see the transient loss of that motor power. Why? Because the the contractions, the movement what we were seeing before reconstruction, that is because of the non-conducting neuroma or partial conducting the neuroma. Once we remove the neuroma, okay, and then we put the graph, the whatever movement we were able to see after the neural reconstruction, we will be there will be a complete flailing, but that movement will be reachieved after a couple of the months, and then you will start developing the tone. Child will start developing the sensation. Initially he was not, he was very calmly and quietly able to do the electrical stimulation because he might not have the sensation, but after recovering in the sensation, they will start registering the electrical stimulation and they will start crying. So that is the sign of recovery in the sensation. Then you will see the flicker of contraction. Child may also feel the transient pain while regeneration. That is called the, Tinel sign. If you are maintaining the surge SD curve, you will see the shift of, recruitment. And then muscle will start developing the girth. And after developing the girth, you will see the noticeable significant movement from proximal to distal. You have to understand that the muscle strength will develop from proximal to distal. And this is for the shoulder rebalancing. And after the shoulder rebalancing, after remove the spica, as I have explained you, there is a lots of restriction in the shoulder, elbow, and wrist joint. So typically we start with the TMR and then aquatherapy, and then we encourage the active assisted movement with the stick exercise. If necessary, you can give the ice pack to relieve the pain, electrical stimulation for the muscle re-education, and then you can use the constraint induced targeted training, strength training program, and then you can introduce the closed kinematic chain exercise. And further, you can add the kinesiotapping and functional electrical stimulation in your therapy program. So this is about the rehabilitation of infants. So here I am concluding the rehab part of the brachial plexus birth palsy. Anybody is having any doubt, let me know. We can discuss further about the questions. Anybody? Meanwhile, I put up one more case study for the So here I am combining the aquatherapy and the TMR. the child he is having brachial plexus injury on the right side. On land, lower side bend on the right side is better than the left side bend. The same thing you can see, the child is having right side bend in the water is better than the left side. Everybody can appreciate, right? On the land, she is having better lower twist on the right side compared to the left side. Now she is having the difficulty to lift her left side pelvis up compared to the right side. And you can see in water also, it's very difficult for her to rotate her twist on the left side. But you can see on the right side, it's very easy for her to rotate her pelvis. Right? Right side bend is better on the land compared to the left. And in the water also, you can see child is able to do the side flexion on the right side better way compared to the land. Upper twist on the left side is better than the right side. And see, in the water, she is able to twist her upper trunk towards left side better way than the right. Okay. Now, we can combine the TMR with the aquatherapy. And this is how we did the deep shortening of all the tight tissues inside the water with the help of using the TMR principles and the aquatherapy principles. So here I am deep shortening the right side bend, deep shortening the right lower twist, deep shortening the right side bend along with the left side abduction. Upper twist. Right lower twist. Combination of right lower twist with the right side bend. You understand that TMR, it's not only for the brachial plexus, you know, it is widely used for the cerebral palsy and the all kind of neuromotor and musculoskeletal disorder, you know. So this is the beauty and this is how we can combine the TMR with the brachial plexus. Thank you. Thank you, everybody. खींच